Уважаемые коллеги, мы можем продолжать работу. Я слышала, что уже Севим Ахмедов на связи.
Dear
Севим.
colleagues, I think we can continue. Sevim, good morning.
Good morning, salam alaikum.
Пока
Good
он
morning.
подключается, я хочу объявить о том, что у нас первая
I
пленарная
want to announce the first plenary session, which is called Global Strategies on we'll have the moderators, Sevim. Good morning, Sevim again. Good to see you. I think we'll give floor to Sevim Ahmed so he could give us a welcome speech, and then we can moderate our. Go ahead, sir.
Parpieva, salam alaikum. My name is Sevim Ahmedov, and I'm the TB HIV prevention and monitoring and evaluation team lead with USAID in Washington. So let me, it's a great honor and pleasure to moderate this first plenary session. And I would like to welcome everyone to this first plenary session, which is planned to set the context for the rest of this conference. But before we start, let me express my sincere gratitude and appreciation to the organizers of this event, and especially acknowledge the national leadership and the commitment of the government of Uzbekistan, as well as Dr. Parpieva, to the fight against TB. It is my pleasure and honor to introduce our first distinguished speakers for the plenary. Although Professor Dr. Parpieva does not need special introduction, she has had a distinguished medical research and program management career, from graduating with honors from the Medical Institute in Tashkent to holding several prominent positions currently as the head of the Department of Phthisiology with the Tashkent Medical Academy, with a combined position as the head of the Department of Diagnostics and Therapy for TB and HIV of the Republican Specialized Scientific and Practical Center for Phthisiology and Pulmonology. She also serves as the director of the Republican Specialized Scientific Practical Medical Center of Phthisiology and Pulmonology. But what really distinguished Dr. Parpieva is her global leadership in the fight against TB. She has set a very ambitious goals for the TB program, as she will walk us over in the next couple minutes, and it is a really honor and pleasure and really privilege to have Dr. Parpieva as a distinguished colleague, and also, if I may, Dr. Parpieva, to say as a friend. So with that, I would like to turn it over for the first presentation to Professor Dr. Parpieva, and remind everyone, if there are any questions, please add them in the Q&A section of the of Zoom, or put them in the chat. Thank you very much, and Dr. Parpieva, the floor is yours.
Thank you very much, Sevim. Спасибо, Sevim, вы так тепло нас представляете.
Thank you, Sevim, for a warm welcome. Yes, indeed, we've known each other for many years. Yes, we are really true friends, and it's really pleasing. I'm really happy to moderate the first plenary session of today's conference. And if somebody does not understand, so we'll have 6 presentations during the first plenary session. And if somebody has questions from among participants, you can send them via chat. Since the first floor is given to me, allow me to introduce you to my presentation. Please bring up my presentation. I would like to talk about the implementation of the national program to end to TB in the Republic of Uzbekistan, achievements and further steps, further goals. Since we are restricted with time, shouldn't be more than 15 minutes each presentation. That's why allow me to talk about important parts. So when I talk about the country, I wanted to change. On the 7th of September, of this year, 2021, the population of the Republic of Uzbekistan has exceeded 35 million people. The territory is the same. So, moving on. In our country, starting from 1994, we started the gradual strategy. So the first strategy which we started implementing in our country, this was a strategy, this was a WHO strategy. And after that, by the way, thanks to the FMS, we were the first pilot project in the Republic of Karakalpakstan. After that, we then covered the entire country. And later, after achieving positive results under this strategy, we then switched to following other new strategies. I think I'm in the wrong slide right now. I will try to get to the right slide. So here we are. So what other reforms were there? In 2009, there was a Beijing Declaration. In 2011, starting from 2011, when the World Health Organization announced about the start of a extensive fight against the MDR. We then developed a roadmap back in 2011. So the activity started according to this roadmap from 2011 to 2015, and in 2012, with technical assistance from the WHO, we developed a national prevention plan against the MDR TB in the Republic of Uzbekistan. And if you look at this very slide, then you will witness that all around the world, including the Republic of Uzbekistan, back in the year 2000, 2001 and 2012 was the peak of TB incidence and mortality rate from TB. But thanks to the law which was adopted back in 2001, law on protection against TB, and then other normative acts and documents, legislative documents, and introduction of all the latest recommendations by the WHO in the Republic of Uzbekistan, we stabilized the situation, and we were able to reduce this number. And you can see the numbers that over the past years, the incidence rate decreased by twofold, and mortality almost by 6 times. And today, there was a figure not 2.1 but 1.2. So the mortality rate in the Republic of Uzbekistan, apologies for that, I am correcting the numbers. So it's of course, over the past couple of years, and then COVID impacted, and I must say here that last year, the Republic of Uzbekistan, just like any other country, when Uzbekistan faced this new challenge, this new infection, and first of all, it's our TB service in Uzbekistan, our regional divisions, units of Phthisiology and Pulmonology divisions, they were responding to COVID, and because there were COVID centers were set up in these institutions, and of course the parameters was reduced in diagnosing TB, and currently we are increasing the capacities of our TB service in the primary section, in the PHC level in the country for diagnostics. I will tell about this later on. So the cornerstone in the fight against TB in Uzbekistan, I would even say revolutionary. There was our current president and Prime Minister then Prime Minister, Mr. Shavkat Mirziyoyev, he issued resolution number 62 on the 5th of March 2011. So this decree by the Cabinet of Ministers about additional measures to reduce TB incidence rate in Uzbekistan for 2011, 12-15. This is a state program, governmental program, which we implemented successfully, headed by our TB service. There was Mr. Mirzagolov Dugmatovich. By creating a new TB team, together with our international partners, we implemented this various state program and we achieved the following results. Number one, the first partial was the motivation involving personnel into Uzbekistan, because when we were starting together with Professor Telashakov, there was only 50% personnel, number of personnel, and the first motivation was to increase the salary for this personnel. Number two, so the fundamental change in creating the material and technical resource base for our work. So we're talking about reconstruction in almost 40 TB institutions all around the country for the total amount more than 176 billion sums. So equipping all these centers, TB centers. So over the past 5 years, we were able to raise the issue of graduality or provision with the personnel from 50 to 83%. Again, this is the personnel. We trained a huge army of personnel. By the way, while training these new specialists, the focus was given to new recommendations by the WHO, World Health Organization, and one of such huge steps of ours, which this is by the way something we started with. We canceled all the then normative acts existing back then. Based on the new recommendation by the WHO, there was one normative document was adopted. It's a table book for any physiologist, which reflected all our normative acts, documents, using which our TB service started its operation. Moving on, here you can see some pictures of the construction. First of all, our head institution, head office, which was being reconstructed under our then Prime Minister, now currently President of Uzbekistan, and we created all the conditions were created for us to successfully fight and work in this new area. So, and of course, so huge, biggest document, the most authoritative document is the decree by the presidential resolution on 13 February 2019, number 4191, about measures to improve the system of specialized physiological and pulmonological assistance or support. So this very document, so the main tasks are reflected in these documents are the following. First of all, this is the restructuring of our service, TB service. In other words, in each and every vilayet region, based on the regional TB dispensary clinics, we created branches of our center, but they are independent legally. These are the regional physiology and pulmonology centers. And the reason is to create comfortable conditions for our population. Instead of coming to just one institution and somebody patient who have experiencing respiratory pains or cases, they can come to our regional centers, and while being diagnosed for TB, so they get treatment in these TB centers, and after diagnosis has done, and if the diagnosis is complicated, then they have diagnostics departments. So for the equipment, large amounts were allocated for the equipping, and it's still continuing. The reconstruction work is underway. Also, the personnel policy, HR policy is also continuing. We're developing the production of, for example, our proposals. According to our proposals, so the country is manufacturing of UV lamps, and we also have various types of means of PPE and so on and so forth. But again, one of the most important points that I would like to draw your attention is that under this state program, there are changes of the vector of prevention of prophylactics of TB for diagnostics of latent forms and development of new regimes for chemoprophylactics prevention of these latent forms of TB. In addition to that, a new principle of financing. This is we're talking about introduction of improved model of financing, and today's conference will give us opportunity to get to know, to learn about the methods to switching to medical insurance, which in Kyrgyzstan they already have that, and we are at the very beginning of transition to this medical insurance. But we also have treatment, palliative TB treatment in Uzbekistan. What we have done so far, several orders. Order number 89 on latent groups on special paths. They are selected and the work is done. This is order number 90 of the Minister of Health. For the first time, this order is about the medical assistance as far as pulmonological assistance, and the fundamental order number 173 back in July, 1st of July 2019 by the Minister of Health. And according to this order, there's been a restructuring done not only of the TB service vertically in the entire country, but also the the man table was also changed. In addition to that, in this very decree, presidential decree, provides for now Uzbekistan is switching to partial procurement of TB drugs, which I will talk about later, and this was in the cabinet minister resolution about simplified procurement. I must say that all these drugs bought from the state budget, everything is done through the GTF. This is with qualified drug qualified by the WHO. So protocols, personnel training. On these pictures, you can see how together with the World Health Organization and our international partners, we've conducted training of more than 600 specialists in our area. So we didn't waste time during COVID. And we had online and offline trainings, as you all are aware, to be able to train new protocols which are adopted in the Republic, which have been adopted in Uzbekistan. But nevertheless, I would like to separately talk about decree number 62. There was a unique 5-level network of laboratories around the country. So over these last years, it's been improved. We are improving, and of course, we enhancing the level of diagnosis at the PHC level. And I can proudly announce that this was our dream to introduce a gene expert, which allows us to, instead of 3 months, now we can do it in 72 hours. We are able to diagnose the presence of microbacteria of TB and the MDR forms of TB in order to be able to start treating from day one and use the right regimen of treatment and complying with the TB infection requirements. And by doing that, I am certain, I can assure you that each TB service in the country, we prevent intra-hospital transmission of TB by observing strict infection control requirements. By the way, the equipment is helping us during the first and second stage of our laboratory services, the newest gene molecular methods of identifying microbacteria. This is old information, by the way, on this slide, because there used to be 65 gene experts, and thanks to the USAID now, and plus our international partner Global Fund, now this number has increased, and we're getting this new equipment. So we're talking about more than 40 gene experts, and yesterday we were discussing this with my advisor, Sharaf Yildash, that it's a 6-color gene. We're already getting gene experts that allow us to identify not only MLO but also XDMR of TB. We have enough number of bactecs in all the regions of Uzbekistan, and of course the HAIN equipment HAIN. And I want to proudly announce that we are always together with our supranational laboratories in Gauting. I would like to thank them separately. We are always in online mode. We work with them together. And the proof to that is all these certificates of quality certificates that our laboratories are getting. Now, shortly about our achievements. As you know, the plan, WHO plan to reach 85% of success rates in all forms of TB. First of all, Uzbekistan reached 91%, by the way. So we are at a very good rate. We're trying to achieve the top point, which is 75%. Now we have 68% in Uzbekistan. So the success rate of short term, again, I would like to repeat here that Uzbekistan is in the region is #1 country in the region, which together with we started developing 9-month courses, and after that we now have multispectral research on introducing a short-term regimen and new treatment regimens, and achieved the beautiful results. And vaccination we started back in 2011. We stopped doing this revaccination. We only do the vaccination covering 99.6% of all newly born infants, and we did not observe a growth of incidence rates, TB incidence rates among children and in the age group. The ones that we used to revaccinate in the past, now we're stopped doing that. So this is a programmatic approach, which in fight against TB among all the population layers, and there's no need to go back to revaccination. We don't see any need in that. We are continuing to do chemia prophylaxis among children So the contacts which we have, and the number that I wanted to give you, of course, it's approximate, but over the past 2014 through 2020, Uzbekistan saved more than 114,000 lives.
Unfortunately, in several countries in our region, there are some sporadic cases of death, and our key objective is to ensure that no family in the future is affected by this disease. And I also wanted to mention immune diagnosis before 2015 to 2016. Since 2009, we had no opportunity to procure tuberculin, and in 2000, production of tuberculin stopped in our country, and definitely much attention was paid to that. And now our country procures tuberculin and their skin tests. So it's state procured, and I have good news. So from the state budget, lately we reached a decision with the Ministry of Health, with our leadership from the presidential administration, to channel the savings from the state budget to procure tuberculin for our risk groups. And I have to say that Uzbekistan participated in testing of quantiferon, and actually it went quite successful. And later on, the plan is to procure, well, I guess, first of all, thanks to our partners, quantiferon will be procured for our country. And as for anti-TB drugs, the plan is to ensure a stepwise transition, and we procured from the state budget first-line drugs and partially second-line drugs, and as for most of the first-line drugs and third-line drugs, so the Global Fund helps us do this. As for international cooperation, it is ongoing. In 2016, as I said before, we opened the first site under to be practical, so it is multi-central international studies to introduce new anti-TB drugs, and in 2018 this site was opened under our center. It is titled the Department for Innovative TB Treatment, and it is my pleasure to mention that among all TB services nationwide, it was our TB service. And thanks to USAID support, here you can see the opening on the 12th of April 2018. So at our service, the Innovative Distance Learning Center was opened, which enabled us to introduce telemedicine, and we opened the hub in our center, and in 7 provinces, similar sites were opened, which made it possible to do telemedicine, and it was especially a high demand during the COVID times. And jointly with USAID and APT team, we are expanding our opportunities, and it was also mentioned today on the 25th of March 2019, when we were celebrating the World TB Day. The memorandum was signed for further cooperation between USAID and the Ministry of Health. On 11th of February 2020, the BCA bilateral collaborative agreement was signed between WHO Regional Office for Europe and the Republic of Uzbekistan. We were especially pleased that the first visit of Hans Kluger as a regional director was paid to Uzbekistan. He was encouraged by the efforts made by the National TB Program jointly with the international partners in the area of TB control. And we conduct multiple briefings. We engage the communities, the population, and over 3 years, over 90 mass media messages were disseminated. So on top of the slide, you can see International Press Club, and in the online mode, representatives of USAID, APT Associates, MTP, Ministry of Health, participated in the briefings. They answered questions asked by our journalists. We repeatedly delivered messages over television, and not only on TB, because we were also engaged in anti-COVID efforts, and definitely a lot was done. So more than 140 articles were published in the leading journals, and jointly with MSF, we publish our articles under Sort IT and the leading global journals, highlighting our achievements. And we always share our achievements. And finally, I would like to highlight the key indicators under MTB strategy. Before 2025, we officially declared the reduction in mortality by 75%, and also the as for mortality rates, the 15% was achieved, and as for incidence rate, yes, actually it is in progress. And what I have to say is that even if the person contracts TB in our country, the treatment is provided and is mostly successful. As for resolution number 4191, the great role is also played by integrated TB control, which is the spotlight of our today's conference, and also the TB in migrants among our countries and other countries. And this problem also receives special attention. I would like to thank you for attention. And if you have questions, once again, a reminder, you can write your questions in the chat. Sivim. Thank you very much, Dr. Parpiv.
Presentation. Thank you very much for walking us through and giving the historical perspective of what a sound foundation the TB program has in Uzbekistan under your leadership. And we always say the political commitment is one of the most crucial ingredients that we need to have in the fight against TB. And it's really great to see such an expression of such a strong political commitment that comes from the side of the government of Uzbekistan and under your leadership for this program to have achieved these results. Given that we are a little bit running short on time, if there are any questions, we will have hopefully some time for Q&A, questions and answer session at the end of the session. But for now, allow me to introduce the next speaker, Dr. Askar Adalbayev, and Askar also doesn't really need an introduction, and I'm sure he's known to everyone who has joined us today at the conference. But Askar is leading the TB program at WHO, the regional office of WHO. In Copenhagen, and he's also a very, very dear and distinguished colleague and friend. Thank you very much, Askar, and the floor is yours for the next presentation. Thank you.
Большое спасибо, уважаемый.
Thank you so very much, dear Sivim, for this opportunity to take the next floor. And I would like to first of all extend my deepest gratitude to the Ministry of Health of the Republic of Uzbekistan, to the National TB Program of the Republic of Uzbekistan, to USAID, KfW, to all partners and organizers of this 5th International Conference on TB Control in Central Asia. It is my honor to speak at this high-level meeting, and I would like to send my best regards from all colleagues from WHO Regional Office for Europe and personally from Dr. Hans Kluge. It is my pleasure to see that at this very conference, all 3 levels of WHO are participating: the country office, regional office, and the HQ of WHO in Geneva. And I would like to share the first slide. Please tell me if you can see my slide on the screen. It is quite challenging for me to speak after the first speakers, especially after those who highlighted quite a few key anti-TB issues in their presentations, and it was also very nice to hear from distinguished Ms. Parpiva on the progress and TB control in Uzbekistan. But in my presentation, I would like to discuss the situation in the region, like what is the current stage and implementation of the TB strategy in our European region. I would like to share the progress and the plans after 2020. So as you are all well aware, in WHO Regional Office for Europe, for the period 2016 to 2020, there was the plan against TB, which set specific goals and objectives to decrease incidence and mortality. And I would like to mention that currently this regional plan is finished, and on the WHO Regional Office for Europe's website, the final report is published, which highlights all the achievements reached jointly by 2020. And namely, I would like to mention that as for incidence and mortality, the WHO region almost achieved the targets reached for 2020 under the TB strategy. And as for the incidence reduction rates, so it was like 90%, although the target was 25%. As for mortality declines, well, over the 5 years, the actual rate was 31%, and the set goal was 35%. But it all happened before COVID-19 pandemic. You are all well aware that in September, in New York, at the UN meeting, all countries undertook commitments to fight TB, and they will need to be achieved by 2023. And now we do have data on achievements over the first 2 years, 2018 to 2019, and I'm happy to present to you those achievements. So the first part is about TB preventive treatment. And the objective was to include in preventive treatment globally at least 30 million people. The share of WHO region in Europe accounts for 2 million in 2018 to 2022. So at the first stage of implementation, we can safely say that, in fact, in our European region, the coverage with preventive treatment for all age groups is not sufficient. Only 9.5% of the reached target of 2 million received preventive treatment. There are multiple reasons for that. Low priority for preventive treatment in many countries in our region, inadequate financing, unwillingness of health professionals, and also the access to diagnostics of TB infection, and also access to drugs which are used for TB preventive treatment. This is also relevant for contacts in families under 5, and namely those age 5, and also people living with HIV/AIDS. And that's why quite recently WHO issued its call for all countries in July 2021, calling for countries to enhance TB prevention measures So targets could be reached by 2023, and all countries will report in 2023 on the progress towards those goals. And unfortunately, TB, as stated before by many speakers, still remains a serious problem in public health in many regions globally. And quite recently, WHO revised the list of countries with high burden of TB, TB HIV, and MDR-TB. And I would like to mention that there were a lot of changes which are relevant to countries and the European region. So as for high burden countries, currently Russian Federation is excluded from that list, but anyway, Russian Federation is on the list of countries with high burden of TB HIV. And it suggests that the problem of TB HIV, so as just mentioned by Dr. Lian Kupins, head of country office, is a very serious problem. And the trend is upward in our region as for this very problem. And as for drug-resistant TB, now WHO is identifying the list of 13 countries with high burden of MDR TB. These 13 countries account for some 90% of the overall global MDR TB burden. And I would like to highlight a very important detail that 9 of 13 countries are countries and European region of WHO, including Azerbaijan, Belarus, Kyrgyzstan, Tajikistan, Ukraine, Uzbekistan, Federation, and unfortunately, as for a drug-resistant TB in our region, as I said before, it's a very serious problem. As for the share of primary drug resistance, as of 2019, it accounts for 17%. As for previously treated patients who previously received treatment against TB with TB drugs, it accounts for 52%. So it's a very serious indicator. And so most of them are patients previously treated in need of adequate, relevant treatment in line with the most recent WHO recommendations. Unfortunately, in our European region, we report annually 70,000 cases of MDR-TB, and mostly these patients are concentrated in Eastern Europe and in Central Asia. Unfortunately, in Central Asia countries, in 5 countries, Kyrgyzstan, Kazakhstan, Tajikistan, Turkmenistan, and Uzbekistan, up to 20% of patients with MDR-TB are notified. The same is relevant for estimates. Estimates of patients with MDR-TB. And so this necessitates a high level of commitment by partners, by WHO, by countries, so we could join our efforts against this severe disease. And I would like to highlight that the goal which was coordinated and relevant commitment were undertaken at the UN high-level meeting in September 2018. So 40 million people with TB globally must receive treatment. WHO European region ensures the universal coverage with treatment and access to this treatment. In principle, over 2018-2019 in European region, 36% of patients were enrolled in treatment programs. And we do hope that the objective 1.23 million to be included in the treatment programs could be reached. But we have to enhance our measures for MDR-TB diagnosis. We need to enhance access to new TB drugs in line with WHO recommendations, and we have to enroll patients in treatment programs so we could reach high results. This slide shows the results of treatment for TB patients. And if we discuss the effectiveness of the STB treatment, drug susceptible TB treatment, overall, our region accounts for quite good results. But I would like to draw your attention to the fact that the TB HIV co-infection demonstrates quite low results in treatment, 51%.
This is according data of 2019. The success of treatment of patients with multi-resistant form and patients which are resistant to fluoroquinolone, which is suboptimal. And according to cohort of 2017, which you can see on this slide, published in 2020, the success in treatment was 59% among the patients of TB patients and less than 50% with the wide drug resistance. This is not the optimal. And these results most probably are related to the fact that during a cohort of 2017, the expansion access to new TB drugs was not big. And therefore, in the next cohort, we are expecting better and high results in treatment of both forms of tuberculosis. Unfortunately, during more than 1.5 years, the entire world is living in COVID-19 pandemic, and WHO, just like many other institutions, has made the estimation and modeling of that the reduction and detection of TB during a certain period of time can drastically increase TB death cases. And this is also related to our region, that the delay in the reduction of the level of registered TB cases can lead to drastic increase of death cases among TB patients. Last year, World Health Organization in our region conducted an overview of monthly registration of TB cases from January to June 2020 in comparison with similar period in 2019. And you can see to what extent pandemic has affected. So reduction of the identified cases in European region in many countries that provided data was equal to 48%. Mostly we link it with restriction measures that many countries have introduced as a response to COVID-19 pandemic. Many patients have stayed at home. Many health services, including TB services, as Nargiz Nusratovna said, were in front line treating patients with COVID-19, and that mostly, and there are many other reasons, of course, which affected the reduction of the detection. This is observed in many countries of our region. So here you can see 6 countries of Eastern Europe and Central and Western Europe, where we can observe similar trend. This is analysis data for January and June 2020 in comparison with 2019. But nevertheless, the trend is continuing now during entire 2020 and 2021. There is a slight improvement that we can observe now, but still pandemic is affecting negatively to the detection of the TB cases. If you pay attention to this slide, so before pandemic, monthly for treatment of multi-resistant form, we have seen 4,000 patients every month. And during 9 months of COVID-19 in 2020, you can see reduction to 25%. So about 1,000 TB patients, since they have not been detected, have not received the treatment. That can lead to negative consequences and increased level of death, which can eliminate all our results that we have achieved till 2020. As of today, we have a big opportunities to improve preventive treatment and increase the
Всемирная организация здравоохранения за период
treatment of both forms of TB. WHO has published a series of modules of consolidated WHO guidelines, which are focused on prophylactic, systematic screening, diagnostics, and treatment of the drug-resistant TB. By the end of this year, we are expecting new updated guidelines on treating child tuberculosis and drug-resistant tuberculosis. All these recommendations, which are being published by the WHO, they're based on the experience of countries, strong evidence-based, and recommended by the WHO for application. And therefore, the assistance of the WHO will be focused on the preventive treatment, systematic screening of tuberculosis in order to improve the coverage by using systematic screening or active detection, by using computer diagnostics of pathologies related to TB and computer-aided detection of tuberculosis. Also, a big attention is paid by EU WHO office on expansion of countries' access to the rapid molecular methods of treatment of tuberculosis. These methods also allow to diagnose tuberculosis, HIV, virus, hepatitis, and COVID-19. And a big attention also will be paid to the quality treatment to drug resistance, so we can make a good diagnosis and start the treatment. Big attention in our region is paid and will be provided in treatment of TB and treatment of the drug-resistant TB. The main message today in the trajectory of the WHO is to transit to fully non-injection, fully perioral treatment of both forms of tuberculosis. And we, as EU office, European office of the WHO, provide support through the regional initiatives, which is a committee of the green light, regional initiative of the modified short mode of treatment, BPAL mode, and new research which is planned now, and the viruses hepatitis C, as well as we will also spend some efforts on nutrition and other treatments. We also expand the access to the digital technologies. We provide assistance and expand the video surveillance during treatment for both resistant and sensitive tuberculosis. This is patient-oriented approach, which is efficiently helping reduction of the COVID-19 and stigma and discrimination during treatment of patients. One of the opportunities to make the virtual consilium or expert assessment. So many countries of Central Asia and Eastern Europe actively participate in this, and we are happy to provide assistance in this. Briefly, I would like to tell about this, and we have a separate presentation on this, which is transition to fully non-injection treatment methods. In USAID, also supported operational guidelines to treat tuberculosis, which is implemented in 14 countries of high priority in European region. These are the patient-oriented work, our initiative, and it allows to reduce the RPM for tuberculosis and reduce 6 times the number of the drugs which has been recommended by the WHO. And this regional initiative is currently implemented in 14 countries where we have 1,400 patients. And many of them are in the Central Asian countries. And video surveillance is something that I talked about already. We call it video surveillance, but not video escort, because we also provide assistance, social, psychological assistance that helps the patients to complete the therapy. And we would like to ask all countries to consider this opportunity as most optimum, and happy to provide technical assistance in this. Social psychological support. Focus on socially vulnerable people. This is one of the priorities of our work. And we will be happy to continue working in this area and cooperate with you and countries in order to study and expand this multidisciplinary approach. Let me also mention that WHO European Office is developing the roadmap of the European region till 2030, which in integration of all the events focus on prevention, increasing the screening and diagnostics, and the coverage of non-injection forms will allow us to achieve the NTB goals by 2030 and eradicate TB in 2035 in our region. And only together and jointly we'll be able to achieve these goals. This document, this roadmap of the WHO European region will be developed by the end of 2021 and provided to the countries for their attention by 2022, and would be happy to receive your contribution to this document. In conclusion, I would like to thank all colleagues in the country offices in Central Asian countries, all member states and partners and local communities, and civil society institutions for their assistance in preparation of this presentation. And thank you very much for your invitation.
Thank you very much, Oskar, and thank you very much also to WHO and to your leadership. Without the work and the policy guidance that WHO works so hard on, we will not be able to do our jobs. Thank you very much for this excellent presentation.
Я тоже присоединяюсь. Оскар, спасибо вам большое.
I also would like to thank Oskar. I'm very sorry that I had to step out to participate in the press conference. Thank you, Oskar. And I would like to invite our next speaker, and especially I would like to introduce you to my colleague, moderator, Sevim Akhmedova, who is for more than 25 years has been working in the public health. He has a big experience of working in UNAIDS. Before that, he worked in NTP Bulgaria. So he has a big experience of work in USAID. And for Central Asian region, Sevim is supporting us in developing plans of work, promotion of our programs. And once again, I would like to say that in Uzbekistan, Sevim is not only our colleague, but a big friend. And I would like to give the floor to him, and the presentation is called Global Accelerator on tuberculosis. Thank you very much, Dr. Parpiva.
I'm blushing. Thank you very much for your kind words. I hope you can see my slides, and let me apologize in advance that I'll speak in English, and thank in advance our wonderful interpreters for the Russian translation. I would like to provide a brief overview of the Global Accelerator for TB. Just look at the historical perspective in terms of the implementation of the USAID global strategy for tuberculosis over the last 5 years. As you can see on the slide, with USAID support, the 23 countries that are receiving direct bilateral support from USAID, we have been able to achieve some significant reductions, both in the TB incidence in the last 10 years, as well as reduction in TB deaths in our USAID supported countries. This is, of course, an example also, though, of the enlightened leadership and the commitment of these countries to work with USAID and with our partners to be able to achieve these significant results. And globally, it is a great achievement that it is estimated that over 60 million lives have been saved in the last decade. Similarly to the reduction in the TB incidence and TB case fatality rates, as you can see, also significant success was achieved in terms of the treatment success rate for drug susceptible TB, and the total number of successfully treated individuals with TB has been over 16 million for the last 5 years for the implementation of the USG strategy on tuberculosis. And although we still face significant challenges when it comes to drug-resistant TB, there also has been progress in terms of initiation of significant number of individuals with drug-resistant TB on anti-drug-resistant TB treatment. So while we acknowledge the significant accomplishments, in 2018, September 2018, as we all know, the UN high-level meeting on tuberculosis took place in New York City, and there were strong commitments from the global community and significant number of countries which committed to the UN high-level meeting targets, which were set at that meeting. USAID also committed to support to provide full support for the to the countries to reach those ambitious targets. And during that UN high-level meeting, the Global TB Accelerator was launched. And since then, USAID, working with partners, working with our national government counterparts, we have been operationalizing the implementation of the Global Accelerator to end TB. And in terms of the programmatic framework and the main elements of that accelerator, were the development of these partnership statements or memorandum of understanding between USAID and the national governments. And it was already mentioned by our honorable ambassador. Uzbekistan was one of the first countries where USAID is working in that had signed this memorandum of understanding. And I would like to congratulate again the Ministry of Health and the government of Uzbekistan for their strong commitment and in getting this partnership statement or the memorandum of understanding signed and approved. In addition to the partnership statement, currently we have over 20 partnership statements.
Помимо этого, мы также заключили похожие партнерские заключения, меморандумы, простите, и они также сейчас реализуются в рамках дорожных карт в странах по борьбе с туберкулезом. И это очень действительно помогает лучше реализовать те принципы, в которых мы пребываем, когда отрабатываем партнерские соглашения. Кроме того, это также реализуется через механизмы работы наших партнеров. Есть определенные достижения. Помимо меморандумов о взаимопонимании, мы разработали более 37 местных специальных соглашений сетевого характера, network agreements, и либо с Министерством здравоохранения, либо непосредственно с программами по борьбе с туберкулезом. Я хочу сказать, что мы очень мощно сейчас работаем в рамках дорожных карт, потому что они действительно очень успешны. И с 2018 года, и вот сейчас следующий раунд закончился достаточно успешный. В ходе реализации всех озвученных мной мероприятий мы все равно не забываем о воздействии COVID-19 и подключаем программы по борьбе с COVID. Исследование, которое было проведено в USAID, оно было направлено на то, чтобы провести оценку воздействия COVID. Вот что мы увидели. Что касается того, что да, действительно, здесь совершенно нет никаких сомнений, уже многие предыдущие ораторы говорили о том, что воздействие было просто катастрофическим. Но, тем не менее, мы увидели сокращение амбулаторных услуг на 50-80% во время периода изоляции. И здесь мы наблюдаем, что больше всего пострадали услуги частного сектора.
Patients reported significant reductions both in initiation or continuation of treatment for those patients. Over 80% of our countries reported that TB staff or TB healthcare workers at all levels of the health system were reassigned to provide COVID-19 response. We also saw that over 50% of our countries reported a proportion of their budget, which was originally allocated for TB prevention and care, was reallocated for the COVID response. And we saw that in more than half of our countries, TB diagnostics equipment specifically were repurposed for COVID-19 purposes. And this clearly translated in some of the outcomes that we saw, and Oskar also presented some of these data for our region. But we saw basically in the 23 countries where USAID works, we saw a 23% reduction of TB notifications between 2018 and 2020. And we're estimating that 23% translates into over 1 million less TB cases were notified in the countries where we work. And just breaking down by region, as you can see, Asia region was the most affected region with the 27% reduction of the TB notifications. But in the middle, the yellow graph indicates the 15% reduction that we saw in our Central Asia and Eastern European countries. In response to the to this COVID to the challenge presented by COVID, USAID, working with our global partners, really in a collaborative manner, engaged in developing and supporting the global development of a global response to the COVID-19 epidemic, which specifically emphasizing the community level early warning and people-centered response, putting together this framework in terms of developing a rapid detection mechanisms that need to be in place to pick up the early warning signals of TB and COVID in the community. The second element of that response mechanisms was emphasizing the early detection as an entry point for respiratory infections through bidirectional TB and COVID testing at the primary healthcare level with a strong nationwide diagnostic network. Thirdly, it was critical to emphasize the household contact investigation system to be developed to screen jointly for TB and COVID-19, as well as development of TB and COVID-19 advocacy campaigns to encourage communities to actively seek care for their respiratory symptoms and encourage governments to continue to prioritize TB care at the same time as tackling COVID-19. And finally, USAID worked with countries to support them to develop costed national TB recovery plans for domestic Global Fund and for USAID support. The Global Fund initiated the COVID-19 response mechanisms, and all of our countries in the region have applied through that response mechanisms for additional funding to address the challenges presented by COVID-19. But also one of the objectives of the C19RM was to mitigate the impact of COVID on TB, HIV, and malaria. What we saw, however, through the C19 application process was that the mitigation objective was suboptimal. What you see on your screen are some of the initial countries that had applied for the C19 RM funding, and as proportion of those applications, TB was only 4% of the total funding approved, and from our perspective, in a way, this was a little bit of a missed opportunity to attract an additional funding to mitigate the impact of COVID on our TB services. Partially in response to that situation, USAID supported the development of the so-called TB recovery plans in 7 of our countries, which were most affected by COVID-19. You see on your screens those 7 countries, and this table also summarizes what are the main interventions that was supported through these TB recovery plans, mainly under the 2 categories of increasing access to services as well as improving the quality of services across the countries. What COVID-19, the impact of COVID-19 as I already said, and what the numbers have showed, was very significant and devastating on the progress that we have been making on TB prevention and care in the last 5 to 10 years. But also what COVID-19 epidemic showed again was that our data systems were also there were still gaps and challenges in terms of our readiness of the data systems to track and monitor the development of this pandemic. And the WHO colleagues, really kudos to them. We need to recognize the more frequent reporting of TB notifications data system.
Region is not an exception, unfortunately, which, although this is a key priority for Eastern European countries and Central Asian countries with the highest burden of DR TB. On the left side, at the bottom, you see the data, WHO data on the patients. The patients with TB who underwent testing by WHO recommended methods of diagnosis and rapid molecular by the regions. As you can see, our region, Central European region, it looks better than other 65%, as you can see, compared to 28% in the global. However, it's not enough. So we're saying that all TB suspects they need to get this test. And when analyzing data in one of the countries, there's a region in Central Asia. I'm not going to talk about it, but they've identified such things like, which is shown in two graphs on the right side. On the first, you can see that one country there's only two.
So the coverage is only 24%. So the needs are currently covered at these three. So there was in 2019, but in many areas the rate is way lower. And unfortunately, as I see it in other countries, Central Asia included, as already mentioned by Dr. Parpieva, we need to work on it, and not only to procure and introduce like GeneXpert and other devices, but we internet. So we also need to enhance our sputum transportation systems and so on. And to sum it up, I would like to show you some useful resources developed jointly with SNAP-TB partnership. So here you can see links to various materials on COVID and TB, and some of the materials on community and gender. And I would like to remind you, well, this slide is in English for some reason, but I would like to encourage you to check with GDF materials. And so GDF is doing a lot in this area, offering a broad range of diagnostic techniques and TB drugs and consumables for various techniques. And several months ago, we got portable digital systems with AI for X-ray diagnosis. So we would like to invite you to become part of it. So to procure this via government sources. Thank you very much for your attention. Wishing you health and every success in this conference. Thank you. Thank you very much, Andrei. That was very interesting informative presentation showing new horizons, new prospects for development of that service in our countries, and you've just showed it quite well. Thank you once again, Andrei. And the next floor, well, since we are limited in time, let me switch directly to that. So I would like to give the floor to Vladimir Antonenko from Gauting Supranational Laboratory. So with this lab, with Professor Hoffman, actually, we've been working jointly for many years. We are friends, and before COVID, when we had more opportunities to organize offline visits, Vladimir and other staff members frequently visited Uzbekistan and showed on site, trained us in new laboratory diagnostic techniques. And I guess Vladimir's today's message about the global update on TB laboratory diagnostics will enrich our knowledge and will open up new prospects for us. Vladimir? Nargiza Nusratovna, thank you so very much for your introduction. And definitely, I do regret I can't make it offline at this wonderful conference. And 2 years ago, I participated in a similar conference, and actually, I was deeply impressed in terms of the level of its organization, and I'm grateful for the privilege to be able to present the latest update on the global diagnostics. Actually, 2001 is the year that offered us a lot of information on the updates and TB laboratory diagnostics. And if you remember, WHO used this very format of guidelines, and since 2007, various guidelines have been published on liquid culture, automated liquid culture, line probe assays, fluorescent microscopy, and so on. And as you can see, there were quite a few various documents which many people found quite challenging. I mean, to understand, especially those people beyond laboratory diagnostics, and in fact, it was quite challenging even for laboratory specialists, given the number of such guidelines, because some of them became outdated. And finally, in 2020, consolidated guidelines were issued, module 3, and the colleagues before me mentioned that. And these guidelines, in addition to rapid molecular techniques, include molecular technique and AAT. And also the guideline includes the latest recommendations for rapid techniques. And also it makes it possible for specialists, for clinicians to follow the model algorithms given recommendations for different groups suspected for TB. And also there are a lot of clinical details with regards to clinical consequences, and also there is explanation for possible reasons for the discrepancy between phenotypic and genotypic test results. And let me present it in chronological order. And I guess like nowhere else in Central Asia region, we face that problem of discrepancies between genotypic and phenotypic tests. And these tests often misguided us, the clinicians, the laboratory specialists, and we knew that there were some mutations that actually highlighted the resistance to rifampicin, and those mutations could be detected using molecular techniques, and relevant strains demonstrated also sensitivity of phenotypical tests for DST. And of course, that was a concern for WHO. And in 2019 and 2020, analysis of various publications was made, so systematic analysis, and in January 18, so 2021, WHO adjusted its critical concentration for rifampicin for DST from 1 milligram to 0.5 milligrams per microliter, and in fact, our national reference laboratories already switched to this new concentration, and we do hope that there will be fewer discrepancies between genotypic and phenotypic techniques as a result of this recommendation. So, as for low capacity techniques, they were on the horizon, and in fact, in 2019, WHO assessed these technologies following several meetings, also with the Global Laboratory Initiative, and thanks to that thorough activity, in early 2021, the document was issued, the rapid advice showing that 4 techniques relying on centralized platforms like high fluoride type Abbott, BDMAX, and Roche-Cobas were recommended for NCP, and the long-awaited technique C8XDR, which can identify resistance to isoniazid, also to low concentrations, and also to fluoroquinolones. And the injectables, which are less needed now. So finally, this technique was approved by WHO. And the methodology of TrueNAP, along with the widespread test, MTB, RIF, and Ultra, it was recommended, and the specification of this technique is the same. It's in fact the analog of that method, and we are pleased to know that now we have options for our countries, and we can select between 2 different techniques, and it's understandable that be able to understand those techniques and to operate them, we need to systematize them somehow. And the new guideline systematize them. So categories of diagnostic techniques for TB were introduced, and the categories relied on the characteristics and challenges of the techniques and type of detection, meaning depending on complexity, those could be moderately sophisticated techniques, or the degree of sophistication could be low or high, and that's clear. So the easier the technique, the better it fits the conditions of peripheral labs. And as for centralized platforms. They are moderately sophisticated. They are more relevant for major central or national reference labs. And all four techniques were included in the updated, consolidated guidelines. So the guidelines issued in 2020 were updated and considerably adjusted since new centralized platforms were included. And now, as you can see, the recommendations include both primary TB detection tests, not only using expert MTB rate, not only TrueNet and Ultra, and also tests using centralized platforms, so NAATs for detection of TB and resistance to rifampicin and isoniazid. On top of that, the method was included, and also the rapid TB detection technique without identifying resistance, and the new group of techniques was introduced to additionally identify resistance to resinamide. And let us quickly discuss the automated NAAT tests of moderate complexity for TB detection and detection of resistance to rifampicin and isoniazid. So the techniques have demonstrated, with regards to TB detection, quite high cumulative sensitivity of 93% and cumulative specificity at 97.7%. So as for rifampicin resistance, the cumulative sensitivity was 96.7% and the cumulative specificity was 99%. And as for isoniazid resistance, the sensitivity is slightly lower compared to that for rifampicin. That's understandable because as for isoniazid, it's more challenging, and in fact, they are more scattered across the genome, and that's why not all mutations scattered around the genome could be covered. But despite that, cumulative specificity was one of the highest at 99.8%. So as for the updated consolidated guidelines, so they also have the wonderful table which can offer information for balanced decisions with regards to introduction of new platforms, and we are getting information on the number of specimens which could be analyzed over one run during one run of the device, and we also know the average time. So if we take 24 samples, like how much time we will need from sampling to result. And also briefly, the complexity of each and every technique, how many manual steps are envisaged, and how much time each step requires. So all four tests based on these platforms became recommended for adults with signs and symptoms of pulmonary TB, and also this recommendation is relevant for primary diagnosis of people living with HIV. It's recommended for adolescents and children based on generalized data on adults. And so far, there is not enough information on its utilization for extrapulmonary specimens. Data are limited, and I guess as soon as countries start using these systems and when we get good high quality data to detect extrapulmonary TB, I guess the situation will change. Automated NAT systems, low complexity for TB detection and resistance to isoniazid and second-line anti-TB drugs. Of course, those are long expected, and Cepheid XDR as well. It was recommended for diagnosis of DR TB in adults with bacteriologically confirmed TB, with or without resistance. And in fact, this test is of high value, especially for Central Asia countries, because it offers a rapid detection of isoniazid resistance. And we are all aware that mono-resistance to isoniazid is quite prevalent in Central Asia countries. And it also contributes to the MDR TB epidemic, since empirical treatment, as we know from publications, empirical treatment of persons with monoresistant form of TB with isoniazid monoresistance is frequently resulted in treatment failure if empirically we treat them with first-line drugs. Then the recommendation is to use that test also for children and adolescents, people living with HIV/AIDS.
Since we already had data about the similar tests, these are ultra tests and others, we knew that this data and system wonderfully works with no lung samples. The data has been extrapolated for SDR tests. So this was a wonderful advantage in detection of the resistance in the case of diagnostic of non-lung TB. The methods of the line probes has been also added by GeneScholar system, and this test allows detecting resistance to pyrazinogyl. Unfortunately, it works only for the cultures, so directly from the samples of the serum, we won't be able to obtain good, reliable results. And the aggregate sensitivity is 81%, which is quite a good specificity. In a new updated guideline of 2021, we have finally shown and seen the consolidated concentration of the phenotypical treatment. This information has been disaggregated in the past, and we had a table of the drugs of the second line. And before that, we have received a list of drugs for the first line, and now we have updated the list of the drugs with compliance, the new guidelines, and along with the rapid communique that has been published in 2021, we have updated the critical concentration of glyphosate. Updates have also covered diagnostic algorithms, which is quite good. And in the guideline now, we have a traceable opportunity of the entire path of the patient through the diagnostics, starting from the detection of the TB, ending with the diagnostics of the resistance and fast method resistance to the drugs of the first and second line. The focus on integrated approach to the patient, reference to the new recommendations on post-screening, and we had more options in the algorithm for the initial test. So except the expert TB, we have entire cohort of the tests, where we now have the test systems of the medium complexity on the nutrification of the nutrient acids, and we have improved the further diagnostics of the RIF cases. We have added methods of detection, the fast methods of the detection by XDR test. So this new method of LPA for identification of the resistance to pyricetamide, and what has been expected for a long time now, and you know that we all were talking about introduction of the sequencing. So in 2021, we have published the catalog of mutations and their association to the resistance to the anti-TB drugs, which will become the reference standards for the labs which do sequencing for new generation. And besides the catalog, we also have the information about the correlation with the minimum inhibiting correlations to different drugs. Unfortunately, the work on this catalog did not result in some specifically confirmed mutations and associated with the resistance to new drugs, especially bedaquiline and others. But I think quite soon we will conduct a very serious work on studying the resistance mechanism to clofazimine and betaclamine, including in Central Asian countries. And very soon we will be able to see the update of this catalog. Thank you very much for your attention. Thank you. So we are a little running late by time, but I think Selim will introduce the next speaker. Thank you.
Yes, I have the pleasure to introduce the next distinguished speakers. Paul Sommerfeld is the chair of the TB Europe Coalition Board. And Paul has been involved with the coalition since its creation, when he led on building links between activists in Western Europe and those in the East. Using his original career skills in facilitation, he has led numerous workshops across Eastern Europe and Central Asia. Paul has been deeply involved in global health for over 30 years, first leprosy, then tuberculosis, and also influenza, with a focus on community engagement and advocacy. From 1998 to 2019, he was chair and now executive trustee of TB Alert, a United Kingdom-based non-governmental organizations with programs in India and the United Kingdom. Also, he was once chair of the then Advocacy, Communications and Social Mobilization Working Group of the Global Stop TB Partnership. He has held several UK public appointments, chair of the National Health Service Trust for Mental Health Services in two London boroughs, and as a lay member in the professional regulation of judges, barristers, osteopaths, and pharmacists. And this is a joint presentation to my understanding. Yulia Kalancha is the executive director of the TB Europe Coalition. She's supporting TB-affected communities and civil society in their advocacy efforts towards people-centered TB care in countries of the Eastern Europe and Central Asia region. Yulia is a specialist in European Union law, and since 2011, she has been working in the field of public health and has been involved in the processes related to the widening of access to treatment at the national, regional, and international levels. The main areas of Yulia's expertise are related to community mobilization and involvement of grassroots communities in international advocacy, development and implementation of advocacy activities and campaigns, as well as monitoring of drugs procurement and medical supplies. Yulia and Paul, the floor is yours. Thank you very much.
Thank you very much, Sevim, for the nice introduction. And it is a pleasure for us to be engaging in this conference on the integrated TB care across the Central Asian region. Our particular message is concerning the engagement of civil society organizations, which we continue to consider to be a very valuable resource, but which in most countries could be used a great deal more than at present. I wonder if I'm not sure how to move the slide onto the next picture.
I think just ask.
Okay. So if we could just move the slide to the next slide. No. Okay. Yeah. And we want in this presentation just to remind you briefly of what are some of the things that you should expect that civil society organizations can do for national TB programs. And secondly, my colleague Yulia will give an outline of some of the things that we are already doing in Central Asia through the auspices of the TB Europe Coalition. So CSOs are very used that with their community engagement are very helpful for adding quality and ensuring real people-centered care in TB programs. And as such, they are helpful for achieving the 2018 UN high-level national targets. We're conscious, however, that at conference after conference, lots of speakers say that community groups are helpful and useful, but that is not translated into very much effort to create or find funding that would make their engagement possible. Thanks to the Global Fund, there has been some significant inputs at regional level, but we would still appreciate to see much more engagement and involvement in supporting and using civil society organizations by governments and national TB programs directly. Just remember, civil society organizations, we may be cheap, but we're not quite for free. If we can have the next slide. One of the most interesting new approaches that has been growing in the course of the last year, and which we in TB Europe Coalition are very much engaged in, is developing standardized packages of care that are delivered by civil society organizations. With the move to health insurance models of health financing, that is particularly helpful to the insurance organizations to know what they are paying for. And so you can see right across the spectrum of TB care, there is an engagement, and there are a number of packages which we are in the process of developing and which we expect to publish with colleagues in WHO and PAS in the course of the next few months. And so you see when we talk about prevention, we are looking at packages on awareness raising, group counseling, on patient education, helping patients know what TB is about, and on latent TB infection management when it comes to the non-clinical component. And I stress the non-clinical component. We're not trying to say that civil society organizations are trying to take over medical tasks, but we can be very helpful in supplementing and complementing those tasks. In detection and diagnosis, we can be very active in case finding. In treatment, we can support treatment observation and manage the problems of loss to follow-up and interruption of treatment. When it comes to care and support, there are packages on needs assessment, on psychological counseling, on social support, on practical material support, on counseling and health education relating to matters such as nutrition and tobacco use, and lastly, on post-treatment social support and rehabilitation. We very much hope that these standardized packages will provide an effective mechanism and handle for both more engagement of civil society organization and for sustained funding of them. I'd now like to hand over to my colleague, Yulia Kalancha, who has already been well introduced by Sevim. Yulia.
Yes, thank you very much, Paul. And we see that CSO kind of, wait a minute, sorry, I will switch off. So we see that CSO can provide direct services in the TB response, and this is recommended by WHO and by many strategic regional and global documents. But the role of civil society sector is not limited to this, because their role is also important in the process of coordination, planning, management, communication, and social mobilization for greater partnership and to generally end TB. And these aspects are considered and are prioritized through national strategic plan in many countries of the ECA region. And we can say that today's strategic planning already looks much more broadly at helping a person affected by TB rather than simply providing TB care in specialized medical institution. And through people-centered approach in TB, we do not treat the disease, but we pay attention to the needs of person, and the person can have whole range of needs, both diseases and condition. And these needs are, for example, to be empowered with information, stigma and discrimination, or helping to overcome barriers related to human rights and other issues. And in all this, the role of civil society and community can also be very significant. On the slide, you can see a number of tools that have been developed specifically to strengthen the engagement of civil society organizations and communities, and to overcome non-medical barriers that people with TB are facing. All of these activities are recommended to be community-led. And with this, I would like to give a few examples of community-led activities besides service provision that countries and national TB program can benefit from engagement of civil society and communities. And as Andrea Mashnyaga mentioned in his presentation, that globally health systems miss millions of people affected by TB because of barriers to health health services, human rights, violations, stigma, and a lack of access to supportive services. And in response to this, the One Impact tool was developed, which is now implemented in 6 countries of the ICA region, such as Ukraine, Kyrgyzstan, Kazakhstan, Belarus, Tajikistan, Azerbaijan, and Georgia. And this is a digital platform, basically an application made up of 3 tools that work together to provide a comprehensive community empowerment, community engagement, and community-led monitoring solution that puts people at the heart of the TB response. And through these tools, people are empowered with information and ways to report challenges they are facing with. Data can be used to respond immediately to people's needs. These tools also aim to provide TB response to support and help national TB program to see systematic and social challenges people are facing with and impact their lives, so that the systematic challenges can be improved and be more reactive to the needs of people with TB. The app implementation also has allowed the country's team to came up with a number of solutions to improve national TB program. For example, to increase the training effectiveness, they began to organize smaller groups of participants to enter into partnership with doctors in medical institutions who conduct trainings on an individual basis, so that they could pay more attention to each patient whenever possible. In some countries, they began to conclude agreements with patients to obtain the right to transfer their confidential data from medical institutions. Also, countries began to practice telephone consultation for patients and involve doctors as expert consultants to promote the application. And there are many more others improvements thanks to this One Impact, a tool led by civil society organization. Another good example is that from 2016 to 2025, countries in ICA region like Georgia, Kazakhstan, Tajikistan, Kyrgyzstan, and Ukraine have conducted community right and gender assessment using Stop TB Partnership individual or integrated CRG tools. And some of the countries had made more than one community-led assessment that contribute to a better understanding of barriers faced by particular key population and human rights, legal system, stigma, and other gender aspects in TB response, and develop reports aimed to assist countries and NTP in particular in transforming the TB response to be equitable, right-based, gender transformative, people-centered, and strengthen the national TB policies and funding application to the Global Fund. It also presents differentiated fundings on stigma and discrimination, gender, financial barriers, and human rights, and propose specific ways forward in each of these domains. For example, this CRG overview found inequity in how different patient groups accessed and remained in TB care, and that the consequences of TB were more catastrophic to some population groups than to another. For example, that women who use drugs and women with a history of imprisonment from these key populations are the most vulnerable and stigmatized. And such findings and data will be used by in-country stakeholders, civil society, and activists engaged in-country dialogues as evidence to guide their discussion, and that the recommendation will be translated into activities and budget. Next slide, please. So what TB can offer to countries to support civil society organization and communities so that they can be more effective and meaningful engaged in the national TB program? As Paul already mentioned, now at the level of ICA region, an important working document has been developed by civil society partners together with WHO Europe. This is a standardized package of supportive services in the field of TB. Depending depending on the budget availability and country interest, TBAC may provide technical support for civil society and community meaningful engagement in TB response. So we can support the practical implementation of this standardized package of community-based TB supportive services and share experience of its implementation from other countries, as now 9 countries of the region are at different stage of its implementation, and there could be different ways how to do it. The other thing that we can support is the national dialogues that can mobilize key populations and decision makers to promote cooperation and bridging the gap in access to TB services. This is an advocacy event and learning by doing opportunity for community and civil society organization. As well, mentoring programs can provide a unique instrument for community leaders and activists to critically reflect on management and leadership skills, which would have a direct impact on service provision in general. Also, we can provide training for mentors to enable local capacity and skills to grow up and stay in country as a part of the strategy that aims to local community ready to take an action. Also, through capacity building activities like, for example, training on soft skills, exchange of experience with the involvement of decision makers during CRG workshops and other training, we can further support practical implementation of knowledge gain during dialogues, including development of practical evidence-based recommendation and advocacy activities. The CSO and communities will be ready to initiate and conduct effective dialogue with stakeholders without external assistance. Also, we can support countries during assessment on the use of multisectoral accountability framework for TB using Annex 2, which specifically related to civil society organization meaningful engagement. And this MAF-TB tool is recommended for implementation for all countries by WHO and to NTB. This support at the national level may include, for example, research capacity building, as when civil society and communities affected by TB are involved in the baseline MAF-TB assessment, there should be specific capacities to support this process. TBAC will propose a new universal protocol which can be adopted by countries for collecting quantitative and qualitative data that complements the baseline MAF-TB assessment. And this protocol also includes the guidelines for organization, the process, and complementing Annex 2, and provides additional data collection tools related to qualitative and quantitative method to measure data, and suggest roles and specific tasks for assessment team members and other documents to support and launch MAF-TB at the country level. So I think I will end here, and Paul, please, your final word. Thank you very much.
Thank you, Yulia. Just to close our presentation, I would just stress that, first of all, TBAC, we already work with partners across all 5 countries of Central Asia. We believe that working with civil society groups, NTPs, are in a position to greatly increase the quality, the real people-centered nature of the programs that you provide. And we would hope that you will be ever more creative in finding ways to engage civil society organizations and make use of the skills and the strengths that they have to help the good work that you are doing. Thank you.
Thank you very much, Yulia and Paul, for this great presentation, and thank you for being keeping on time. This was our last presentation for the morning session, and we had very interesting presentations, very rich data information as well as experiences that were shared this morning. Unfortunately, we're also quite behind the time, and I know for some of you that you are there, we're keeping you away from your lunch. But I will turn it over to Professor Nargiza Porpieva for her final words as well. And just to say that in terms of, there were some questions that were answered either in the chat or in the Q&A session. But if you haven't had your question answered, please repost it again. Thank you very much.
Thank you very much. And да, на самом деле, Севим, вы совершенно...
Thank you very much, Sevim. You are exactly right. We've received a lot of very comprehensive and quite novel information, which will be of an interest for everyone, for all the participants. And it was quite fruitful morning, I'd say. We've listened to all 6 reports. The only thing is that welcoming remarks were quite lengthy, I would say. So everyone wanted to report, and a lot of interesting information was there, and we were not able to interrupt. So we are late for 50 minutes, almost an hour. So once again, I'd like to emphasize that. First of all, I'd like to thank all the presenters, Sevim, my dear colleague, co-moderator, and I'd like to say the following. So I'm truly hopeful that, first of all, should there be any questions? Yeah, we actually were planning on having Q&A session, but please do it in writing. So if we see them in chat, definitely later on, we will find time to respond to them. And the presenters, should there be a targeted question to one of the presenters, so we will pass it on. So my proposal is to have a break, of course, till 1:20. So let's have it for like half an hour. So, because for the countries which will have to share their work of NTP on the impacting and combating with COVID in Central Asian countries, so we will split them by hours. See? So please. So, well, 1:20. That's the time for our next session. Thank you.
Уважаемые коллеги, я надеюсь, вы смогли передохнуть. Жалко, конечно, что вы не в Узбекистане. Мы бы вам предоставили... Уважаемые коллеги, я надеюсь, вы смогли передохнуть. Жалко, конечно, что вы не в Узбекистане. Мы бы вам предоставили нашу и очень вкусную кухню. И, конечно, у нас сейчас пора созревания дынь, и винограда, ну, изобилие, конечно. Но я очень надеюсь, что в следующий раз мы сможем провести и оффлайн, и тогда мы, конечно, добавим к нашему радушному приему еще и нашу кухню. Но я думаю, что нам надо приступить к
However, I
следующему.
truly think that we have to start our next item of our agenda, and we have the presentation from the countries, from the NTPs. Since in Kazakhstan, Malik Moldabekovich has an emergency almost situation, they have a visitor there, so I'd like to pass the floor to my colleague, the director of Center of NTP in Tajikistan, Asledin Rajab Zada, please. Tajikistan.
Уважаемые коллеги, кто у нас находится сейчас в
Dear
онлайн-связи,
colleagues, those who are online, we have technical delay because other countries are joining us. Do we have? Yeah, who exactly do we have? Tajikistan. So not to have any delays, once again, I'd like to emphasize that the first floor will go to the head of NTP Tajikistan, Asledin Rajabzada, please. Good afternoon, esteemed colleagues. Do you hear me? Do you hear me well?
и видно. Добрый день.
Yes, and we can also see you. Thank you, esteemed participants, the organizers of 5th International Conference on Integrated Tuberculosis Control in Central Asia. It is my great honor to be a part of this conference and to present our report, and thank you so very much that we have so many participants from a number of countries. Even though we're far from the steering committee and we're here in just online mode, but still we feel that we are part of this event, because we think that even virtually we are well communicating with each other. So in April 2020, we've had first case of COVID-19 in Tajikistan, and based on 30th August 2021, the number of total COVID cases reached up 16,778. So 0.2% of total population of the Republic of Tajikistan. What had happened in the beginning of pandemic? Pandemic has impacted, of course, unprecedentedly to the public health care due to a lot of risks and barriers in providing main medical services, healthcare services. There were high risk of disruption in supplies of basic medical drugs and also medical materials globally. A concern of number of people to seek healthcare help based on the COVID-19 was obvious. So that's why the whole system has weakened, and the access to clinical services has been reduced. And also we had problems with vaccination, etc. So as for the capacities, we only had 10 laboratories which were capable on doing PCR. By the assessment of WHO, we're supposed to have 25 of them. So we were lacking also a number of tests that impacts the burden, of course, additional burden to the medical personnel. And that was quite obvious. A lot of financial and medical resources and human resources has been diverted to COVID service. Sudden need in financial support was quite obvious. So we started to be faced with financial deficit in the healthcare. Suddenly, we started to have a lot more patients all over the system. So that almost jeopardized the whole system. Sudden increase of burden on civil society organizations. So the efficient implementation of their activities has been also jeopardized. The impact in combating TB, well, that was also obvious, and that impacted global measures combating TB. And we've decreased screening capacity, and also that was obvious worsening of that capacity. And then we were also unable to detect TB timely, reduction of patient enrollment for treatment, efficient clinical management of TB cases due to self-isolation. And of course, exacerbation of TB stigma and discrimination. So immediately we were able to establish a working group to involve our partners to improve the situation with TB. We've developed the pandemic response plan within the TB service. Then we started to strengthen the infection control in the context of pandemic and development, and also the proper means to support our patients. So besides the order of the NTB to all TB centers on management has been provided with we had to perform our task in covering all the TB centers. So we had to provide all anti-TB drugs to patients for a couple of months to cover them completely. So that was the way out, of course, and also TB treatment mainly at home. This is what happened. So under the control of the volunteers and social workers. So we had a lot of partners helping us. Then provision of video duty and family duty to committed patients. Then we've also developed mobile phone-based tracking. So development of temporarily TB diagnostic algorithm. This is what we've done in order to support our system to properly provide the resources. So, of course, we had all our borders closed, so that's why traveling was not possible. We had travel restrictions. So, of course, we started to lose the opportunity at the treatment at the initial stage. So we started to have late referrals to anti-TB services. So, and also there was a lot of delay in diagnostics because we were lacking diagnostic, not only like diagnostic equipment, but also supplies for ATBD. So then we were also unable to cover everyone. And later on, we started to have late addressing to the TB services during pandemic that brought down to the increase of the numbers of deteriorated TB.
Of the TB patients taken for treatment decreased by 12.3%. In the second quarter of compared to the second quarter of 2019, such a reduction in the TB cases poses high risk of sudden inflow of high cases of TB incidence in the coming years. In this slide, we are showing the incidence rates and mortality rate and success rate for the period 2010-2020 for the Republic of Tajikistan. As you can see, in 2020 compared to 2019, I want to draw your attention to this very slide. The incidence rate year after year was decreasing, has been decreasing by 1.2, 1.5 parameters, but we have a sharp decrease of this. There's more than 15 indicators in 2020 compared to 2019. The indicators, I mean. So this is in comparison with 2019. So the mortality rate is at the same level. This rate indicated just like in the previous years during COVID-19 pandemic did not affect the TB services because in 2020 compared to other years in Tajikistan, as you can see from this slide, and there's an annual reduction of by 0.2, 0.5, 0.6 indicators. Success rate again with treatment success rate again has reduced by 2 indicators, and again you see here by the regions as well the incidence rates by the regions in Tajikistan. But compared to DRTBs, here you have by months. We're showing by month compared to 2019. Among all other cases in January of 2020, it's not a big reduction of incidence rates because like I said, starting from the second quarter of we registered first cases of COVID-19, and starting from the second quarter we started there was a reduction starting from April. You can see from the slide compared to the April of 2019, there's a sharp decrease in the incidence rate by 160 patients. In 1 month, there's been a reduction in incidence rate. Again, in same thing in the first quarter of 2021, there's been a reduction of cases, TB cases, and on annual months, there's a decrease of the incidence rates in TB. Now, DR-TB treatment, again, we've seen some reduction here again compared to previous years, but there's been measures taken to address that, and we started to actively work in that there. So currently we have both new cases, MDR cases. There's been sharp increase of MDR cases, and in 2021, as you can see here from the slide, in August, after our analysis that we conducted, we noticed that there's been approximately increase by five indicators of incidence rate compared to same period in 2020, and we're hopeful that if it continues, we will be able to reach those goals that we were set. Possibly there's maybe USAID, in accordance with the UNDP, they've conducted a modeling research assessing the potential impact of COVID-19, the epidemics, to TB program in the Republic of Tajikistan. By modeling, we assessed the growth of incidence rate and mortality rate from TB within the next 5 years. We've modeled two scenarios. First being the moderate outcome of TB services, in which the entire TB services they are recovering to normal state within 4 months, starting from November 2020. In other words, there is no so this is a blue line here, and scenario number 2, it's interruption, where the tendency that we can observe in November 2020 is going to continue another 5 months. In other words, until the May of 2021. This is the red line on the slide. If you can see it, this is right here. This is on the slide. It's shown on the slide here. In conclusion, I want us to say here that even temporary interruptions in the work of TB services can significantly impact mortality incidence rate in TB in the Republic of Tajikistan within the next couple of years. But however, any efforts to recover the lost undertaken right after these interruptions that can contribute to improving the situation and bring to long-term positive results and help with these interruptions that have taken place in the past. I have on the previous conference on those things that we were supposed to do according to the requirements from the previous conference, and on the resolution as well. So what we were doing, so we developed and approved by the government of the Republic of Tajikistan new national program to protect the population against the TB for the period 2021-2025, increasing the financial resources which will be effectively used to implement TB program in the Republic of Tajikistan, ensure the full coverage qualified services for prophylaxis, for prevention, early treatment, and dispensary follow-up, including the TB services. There's 56 gene expert equipment, 7 digital X-ray, 7 mobile vehicles that we have in Tajikistan. Improved access to diagnosis to TDR, TB, and then using new methods starting from February 2021 in the regions of districts and regions of Uzbekistan. We actively we are widely using new drugs with the shortened regimen for all kinds of DRTB patients with the necessary follow-up. Within this operational research, starting from 2020, we are using new treatment regimes against DR, against MDR, such as BIPAL and MCRL modified shortened injection treatment regimens. Right now, we're talking about 60 patients and 16 patients are taking BIPAL. They're getting BIPAL treatment. So the country has developed and approved a number of legislative documents and new approaches to prevention and timely diagnostic and treatment of TB in children. We've extended the methods of inducing and procurement of drugs for the children and for the diagnosis to treat TB. We are improving the immediate measures to integrate necessary services for the patients with the mixed infections. The country is using the best advanced practices involving the civil society in implementing anti-TB events. We're focusing on vulnerable groups of population, including migrants, prisoners, ex-prisoners, and HIV people living with HIV, considering the human rights and gender aspects as well. Thank you for your attention. Thank you again. If you have any any questions, please, you're welcome. Thank you very much, Aysuddin Saidburkhanovich, for very contentful, very informative presentation, and also for the progress in fulfilling the resolution from the previous conference. We will take that into consideration when developing resolution of this very conference, which will be, the draft will be distributed among all the participants of today's conference. So let's switch to the next presentation, which will be given by the director, head of the National TB Program of the Republic of Kyrgyzstan, Professor Karatayev Madamir Musayevich. Please, you have the floor, sir. He's not with us. Hello, good afternoon, dear participants of the 5th conference. Allow me on behalf of the National Physiology Service of the Republic to welcome all of you on this very conference and express gratitude for the organization of this very forum. As was already pointed out, it's indeed the impact of COVID-19 to fight against TB in Republic of Kyrgyzstan. So the Kyrgyz Republic is the smallest in terms of population in the Central Asian country. So that's why only 6.5 million people, and the territory is only 200,000, about 200,000 square kilometers in Kyrgyzstan. And the pandemic 19, indeed, for the first time, on the 18th of March, there was a first case registered. COVID-19 was registered for the first time. There has been very first 3 cases at the end of March, from in the period of 18 through 23 March. Just like in other countries, we also announced the emergency situation, as you all know. So here we're talking about the restrictions for movements, patients that could not come to medical or other institutions, but the patients, TB patients, this is a high risk. This was complicated during COVID-19 because they interrupted the TB treatment, unfortunately. But according to the order by the Minister of Health of the Republic of Uzbekistan, many departments, many territorial hospitals, TB hospitals, private of the National Physiology centers, they've been requalified to respond to COVID-19. Even the laboratories, since April 2019, they started testing for COVID-19. We all know that in 2020, the highest peak was in July, which we call the very first wave. The second wave was in November of 2019, and currently we have, starting from 6 September 2021, 478,000 and more than 2,566 deaths. Unfortunate. This is very unfortunate. Madam Musayevich, please check your microphone because we stopped hearing you, sir. Please check your microphone. Please turn on your microphone, sir. You muted your microphone, sir. Can you hear me now? Yes, we can hear you. Apologies for that. Apologies. Again, what measures were taken? Here, again, number 1, changes to organization of the treatment, enhancement of the infection control measures in the healthcare facilities, support to patients, and monitoring of the treatment, and improvement of the awareness during COVID-19. Lost him again. Well approved by the order by the Minister of Health, as my colleague pointed out. Also, we also have anti-TB drugs for 14 days. So direct control of treatment, different types of treatment control, and here we included the among the family members and also public supporters, the online TB consultants to provide continuity of monitoring and treatment of those patients that are undergoing treatment. The most important issue was the infectious control of the TB in the organizations. Again, as was already pointed out by several times by previous speakers, because of COVID-19, we revised the internal algorithm on infectious control. We approved a new procedure for working in red zones, reference laboratories for testing for COVID-19, with measures of infectious control, and the personnel of TB system within TB system and TB services, they've trained the different measures, and they have the PPEs as well. And support to TB patients and events to improve the awareness and inform. This was one of the main tasks. Here again, there was a social support that by the nurses and the Red Crescent. Social workers also helped with support from USAID. We gave out product packages. We also mobilized local communities to help the TB patients. We distribute information about through informing, talking about symptoms through websites, social media of the Minister of Health and Social Development, National Physiology Center, Fund of Compulsory Medical Insurance, and many other partners. In addition to that, the official information channels on TV, radio, and mass media were also used to increase awareness. How COVID-19 impacted to TB assistance and TB service? Yes, it's true that there's been a decrease of diagnostic or microscopic research done at the PHC level. There's been a decrease of the volume of sputum to central transport system. This is we're talking about National Republican Reference Laboratories from all treatment of tuberculosis and management of cases. Number of patients has decreased. I mean, because there's been a very few number of patients at the hospitals, and support to patients in regards to the adherence to treatment. Again, as we can see on the statistics dynamics of the mortality incidence rates in the Republic of Uzbekistan over the past period has a tendency for reduction. According to last year, as you can see on this slide, for 2019, 2018, there's been a sharp decrease, 32.2%. This is the incidence rate that tells us that this is related to I will talk about it later. This has to do with the low approach rate by the patients for the TB treatment and for low turn up at the laboratories. The impact of COVID, as you can see here, here we have in the first quarter, red line, TB, and the blue is COVID. In the first quarter there were 262 cases, and it was the highest peak in the third quarter. This was July. Here we have 39,000 cases, 622. Here we have the similar reduction in the second quarter by 40%. By 42.2% in TB detection, and in the third quarter by 50.3% reduction. As we can see, compared to 2019, 2018, these tests conducted on DR TBs and using the anti-TB drugs, you can see we can see the sharp decrease in the second quarter. Again, 47.6% for DR. And in the third quarter, 45.6%. And as I already mentioned, we had a second wave, which was in November. Again, here we see a total number of 39.4%. If you look at, here, so we have in the third quarter, so there's been a decrease by 63.1%. COVID impact to TB services. These are the data on the quality of TB services done under the USAID and TB in the first quarter of 2021. We had 289 institutions. We're talking about different primary, secondary, tertiary, and depending on the town or village, we covered the entire country. We had a questionnaire of more than 1,000 medical providers in 7 regions of Kyrgyzstan, and we interviewed 740 patients. What data we have? So as you can see here, we have 60% of institutions in the entire country reported that COVID-19 impacted the TB services. 33% they reallocated TB finances to respond to COVID, to buy the PPEs. 63% of institutions, they've moved the personnel that were initially providing to TB to respond to COVID. Here I wanted to mention about the personnel that was used to the maximum in responding to COVID. So they are supposed to now respond to COVID. Again, 61, so we've converted the best to COVID, and 48% for DR TB and 55% for NDR TB. 11% of cases, institutions, they reported the deficiency of TB drugs before the. Here we're talking about deficiency of first-line drugs. 11% to Revan institutions.
10% of facilities indicated that they had deficit line drugs and second-line drugs, 11% and 24% respectively, and actually 78% of facilities indicated that they were engaged in contact tracing, and it also produced its impact. And 39% of facilities noted decrease in TB cases enrolled in treatment since the start of COVID-19 pandemic, and 58% is the reduction in the number of patients under control by health facilities. And as for the highest reduction is the primary level, 51%, and the secondary level, 40%. So as you can see, we have 280 patients. So it's the average daily number of patients with TB undergoing treatment or treatment monitoring before COVID-19 pandemic. So, and the reduction at the primary level is from 6.4% to 2.4%, and at the secondary and tertiary level, the reduction is quite comparable. And as for the infection control, 57% of facilities enhanced their infection control techniques in response to COVID-19, and 98% of facilities reported adequate number of personal protective equipment, mostly at the tertiary level, and 70% of facilities regularly test their personnel for COVID-19. So the conclusions are the UTSA results show considerable disruptions in TB service operations due to COVID-19 in all areas: diagnostics, treatment, TB contact tracing, and so on. And the initiatives of the NCP in response to COVID-19 in 2020 made it possible to mitigate the impact on TB and help the patients continue their treatment. And most of the initiatives continued on a sustainable basis, like online counseling, online support groups, and enhanced infection control. So what we suggest is we need to enhance anti-TB interventions via integration with approaches developed against COVID-19. Train the population and health professionals in cough etiquette, ventilation, wearing masks, and then we need to ensure a triage of visitors in parallel screening of contacts, and then we need to enhance the approaches for active TB detection, both at the facility level and at the community level. We need to introduce the FAST strategy at health facilities, mostly at PHC level and general hospital. And then we need to enhance contact tracing activities, strategic planning for a TB laboratory network, ensuring access to high quality laboratory diagnostic techniques. And here, in fact, our national reference lab is working. And what I mentioned before is transportation. So we plan to open the laboratory in the south, so people don't have to go to Bishkek, and so tests could be done in Osh city. And then also we plan to ensure development of new programmatic information programs based on the priorities for TB care, and then further expansion of TB case management. So high quality transition to short-term oral treatment regimens and adherence treatment, and also we need to enhance TB preventive treatment, especially for people living with HIV and children under 5. And let me focus on the interventions conducted in Astana, and as mentioned before by our colleague from Tajikistan. The resolution mentioned above is being implemented, and you can see that at least 90% of detected cases are being treated successfully, but unfortunately in recent years, as I said before, it's due to the impact of COVID-19. And we actually have hope that we will finally reach our targets. And as for financial resources, so we are making efforts to ensure self-sufficiency. And as for procurement of second-line drugs, well, we procure first-line drugs from the state budget, and now we are planning to do the same for the second-line drugs. And that's for access to prevention, early detection, as for access to dispensary observation. So now we are referring to not only mobile teams, but we will focus on prevention and case detection. So as for border control and migrants, so we border on China, Uzbekistan, and other countries, and so we work closely with our colleagues from Tajikistan, Uzbekistan, and Kazakhstan. So as for pharmacovigilance, it's in progress, and also we conduct operational studies. And in that regard, the Astana resolution is a result of the 4th International TB Control Conference. So as possible, we are implementing it now. Thank you. Thank you very much, Madamin Musaevich, for the information provided, for this opportunity to take a look at Kyrgyz experience. And in the context of pandemic, definitely there was some impact on TB detection in the region. And the next presentation will be made by a representative of Kazakhstan. Now I would like to give the floor to a representative of NTP of Kazakhstan. I guess Malik Moldabekovich will not be able to present it. So please introduce yourself. Please switch on your camera.
Уважаемые коллеги, у нас связь
Dear
прервалась,
colleagues,
поэтому
Kazakhstan
я
got disconnected, and that's why I suggest we finish the plenary session and we will hear from our colleagues from Kazakhstan after the results of discussions and sessions are presented. And now I invite you to sessions. Please follow the link you have and go to your respective groups. So the sessions will start in 5 minutes again. To make it convenient, so you could follow your links, and then at 2:25 parallel session will start. Once again, I would like to extend my gratitude to our facilitators, Dr. Svim Akhmedov and Professor Parpieva Nargiza Nasratovna. And with your permission, this is the end of the plenary session. Thank you.
мгновение остановиться на регламенте наших сегодня выступлений. Пожалуйста, не затягивайте время. Каждое выступление длится ровно 15 минут, и за 3 минуты до конца я буду в чате писать сообщение, что пора закругляться. Также вы видели общий регламент того, что когда вы входите в систему, вы включаете и свое видео, и свою презентацию, и, соответственно, после того, как ваша презентация закончена, вы отключаете свое видео и свою презентацию, дабы дать возможность своему коллеге.
Immediately when you are done, please turn off camera and switch off your presentation. I'd like to pass the floor right now to Bigzad, and she will be announcing our first presenter. Thank you very much, Dmitry. Good afternoon, dear participants of the conference. Allow me, first of all, to express my deepest gratitude to the Republican Specialized Scientific and Practical Center of Phthisiology and Pulmonology of the Republic of Kazakhstan, and to all the partners for this great opportunity to get together and to discuss matters which are very much important in managing the cases of TB. So since we truly have quite limited time, I'd like to pass the floor, and that's the presentation on the implementation of NGS, experience of Kyrgyzstan and Kazakhstan. So first floor goes to the head of Ref Lab at the NRL of the Republic of Kyrgyzstan, Gulmira Kalmabetova. She is PhD, and she is an honored doctor of the Republic, and she's member of Eurovoice Lab and technical member of the member of technical group. So please, Gulmira, the floor is yours. Dear Bigzad, thank you so very much. Dear colleagues, allow me to welcome you at this conference and wish you strong health, of course, and successful work at our plenary session. Bigzad, may I ask you to share your screen? Because my conditions would not allow me to do this. I do not have access to my presentation, unfortunately. 1 minute, please.
Добрый день. Если что, мы можем вывести из Ташкента.
Yeah, from Tashkent, I may share my screen. Yes, please. Could you share your screen?
Видно ли презентацию?
Do you see the presentation? Yes, thank you very much, Dmitry. Yes, my dear colleagues, allow me to share with you the experience of implementing of sequencing the full genome to perform diagnostics of TB with the countries with low level of income and high burden of the MDR, I'm sorry, just like our country, Kyrgyzstan. So what exactly is the outcome of performing sequencing of the full genome? So full genome sequencing is very much important, which is revolutionary. So I will be referring to that WGS or MGS because it's a revolutionary application and which is needed for diagnosis of TB and mutations. But also, I'd like to emphasize that implementation of that in the countries with low or middle income, it is faced with number of matters. As for the sequencing started in our country, so the whole project on implementing sequencing and under the support of USAID under the project DefectTB, so has been implemented within 93 weeks and has been launched in 2017. So all the equipment has been provided to the Ref Lab in 45 weeks. after the procurement process has been done. There were delays, of course, due to the lengthy delivery and customs clearance. Implementation of MGS took us 50 weeks, measured at the time between the first training and the first autonomous WGS for our lab experts. Well, that was important. So as for the country of Kyrgyzstan, the way we calculated and what exactly the equipment which we needed, how much sequencing we could perform, etc., etc. So we were based from the following. So our country is one of the highest, was one of the highest burden, and for the beginning of 2017, when the project has been launched, like Stop TB. So the morbidity was 144 for 100,000 persons. So, and 7,000 plus cases has been registered down by the national program, out of which 3,502 had bacteriological approval of the confirmation, and out of them, 1,037 were confirmed with MDR as MDR cases. So as for the bacteriological confirmation for XDR, we only had 134 cases. Next slide, please. So what, well, based on these numbers, what were the capabilities that we've had? What exactly we wanted to implement within the framework of this project, and what was the requirements to establish the platform to perform the WGS? So the first stage, we had to identify the requirements, of course, and the requirements of WGS platform was the following. So that would be best suiting for the needs of Kyrgyz TB program, and they were calculating using the EPID figures outlined above. The complete resistant pattern of all the cases confirmed. So we had to apply the proper national TB diagnostic algorithm, and for that, we had to identify for all the confirmed cases, taking into account the possibility to expand WG to 10 up to 20% of bacteriologically confirmed non-MDR RR pulmonology TB cases for surveillance, because that was needed. We came up to a result that so the throughput should have be in 2000 up to 2,900 sequencing per year. So that would equivalent to 55 sequences per week. So we have, that's why I chosen the MySec platform with a capacity of up to 30 MTBC genomes for one run, and 2 runs has been done per 1 week. So as for the expenditures, the procurement ones, so there has been classified based on the net prices and also the gross. So that's the unit price plus additional costs for insurance, transportation, customs handling, consultations, and administration for the procurement. So the first run was there for, so the consumables that we were able to obtain was sufficient enough for 2,000 DNA and extractions and 800 WGS sequencing. So real per sequence cost were calculated after the first 174 WGS by dividing the costs of actually consumed materials by 174. So theoretical long-term per sequence costs were estimated based on the use of the MySec reagent kits version 2, 500 cycles, and version 3, 600 cycles, under the assumption that they are always completely consumed with the optimal number of samples. So here we have the information with regard to procurement of main equipment. We also have information for the procurement of additional information for reagents and other expenditures. Well, I don't want to cover it in detail because due to time management constraints. So I think that my presentation will be shared, so you will see all the numbers if need be. Next. So as for the cost of equipment, so it is there in the table, which has been shown before in my slides, and that's why allow me once again to omit the slide, but the information, once again, I'm repeating myself, but the information is accessible. You may take it anytime and check it anytime. The only thing which I would like to tell you additionally, in order to sequenize 174 genomes, we needed reagents, and it took us 2 months from the moment of order down to the door of the lab. So that because the short guarantee shelf life was only 3.5 months for the kits Nexiria XT. Next one. A lot of people are asking the question, what was the cost per sequence per one sample, for example, because the experience of implementing sequences that we have in the countries with low income, as it was mentioned before, it is quite rare case. And that's a procedure or process, quite challenging one. So if at the moment of the beginning of the project, the cost was somewhat about $300 US, then after sequencing of those 174 samples, the cost has reduced, and because we've switched to V3 kit. So that was version number 3 for 600 cycles, and the cost now is $141 US. So as for training of staff and personnel, which was a key for our country. So then at the moment of the beginning of the project, there were 2 staff members of Kyrgyz NRL were trained. So in Germany, in Gautinki and Bostel. Besides, our partners came to our country to perform on-the-job training under our conditions, and also representatives of distributing and manufacturing companies came as well. So they've performed number of training courses. They trained on the job, and the cost of training was for the whole cycle of implementing the whole project was somewhat about 48 plus thousand US dollars. Can I go back to the previous slide, please? Couple of words. So as for the training of the personnel, so as we understand, it was just basic training course, and we are in need to provide, and like for us to provide better analysis and better information, we need advanced training course on how to apply sequencing method as well. But the most important thing is to have training courses on bioinformation. Thank you. Next slide. As for the external quality control for WGS, I may say the following. At the moment, there is no standard approach to perform the assessment, and this is why we were applying interlaboratory confirmation. So to truly see if the quality is meeting the international standards. So the description on how did we perform I'm sorry, I cannot hear the speaker. Is this just me or everyone?
Дмитрий.
Да, Гульмира, вы пропали на...
Yeah, we lost you, Gulmira, for a couple of minutes, so yeah, it's okay, you came back.
Слышно?
Да, сейчас слышно.
Now, can you hear me well? Yes, thank you very much. So, it was successful comparative work, so there was 95% of the compliance. So, next slide, please. So, as for working under pandemic, so I'd like to express my deepest gratitude to the government of Germany for given opportunity, for their support during pandemic, and our lab has been involved in PCR testing for corona, but the support on behalf of the project, on behalf of our partners, never stopped. Besides, they supported us in implementing the sequencing of coronavirus genome sequencing. Besides, one of our main partners is the regional office of European WHO Bureau. And besides, the team of GIZ was with us, national team for rapid deployment. We also have our supportive experts from Martinovsky's Institute, also WHO Charité Berlin, and trainings of sequencing on SARS were done for 11 participants. Also, Department of Prevention of Health, Lab of Genetic Researches. And based on the result of implementation, we were able to starting up, as I told you already, the SARS-CoV-2 genome for 11 participants. So the platform that is being applied in our country is with great capacity. So the lab capacity was also very strong to provide not only sequencing for TB, but also for coronavirus as well. Next slide. I'd like to express my deepest gratitude to USAID for the given support, and I would like to thank you for allowing us to be part of this adventure to introduce sequencing with the country, within the country with such a low income and high burdens. Thank you very much. I would like to thank the FACT Associates. I would like to thank also supranational ref lab, Dr. Harald Hoffman and his team, Dr. Stefan Neyman and his team.
Нашей команде национальной референс-лаборатории и Национального центра фтизиатрии за ту работу, которую мы проводим. Спасибо. Дмитрий, floor is yours.
Большое спасибо, Гульмира. Спасибо.
Большое спасибо, Гульмира Исмаиловна.
Бигзат, можно я добавлю буквально?
Да, пожалуйста.
Thank you so much, Gulmira Ismailovna. So I can see there are questions, and I can see there are two questions for Gulmira. from Stopdan, and actually the procedure is that questions will follow all presentations. Now I would like to give the floor to Bigza again, and the next presentation can start right now. Thank you so very much, Gulmira, for your very interesting presentation. I would like to congratulate you on the successful introduction of sequencing and wish you every success later on. And the next presentation will be on Kazakhstan's experience on the sequencing of MTB. So Leila Chingisova, head of National Reference Lab, the Republic of Kazakhstan. So she is the doctor from Kazakhstan. So shall I demonstrate my presentation or what? Yes, we requested that organizers do that. If you can do it, it would be good. So you can regulate it yourself. Can you see? Yes, it's all visible. So, good afternoon, Bigza, Dmitry, conference participants. First of all, I would like to thank the conference organizers for this very opportunity to participate and to speak at this conference. Second, it is my pleasure to share experience with introduction of NGS in Kazakhstan. Could you please press F5? Zoom in, please. Is it okay? Thanks to stable financing of national anti-TB programs, development and implementation of innovative TB diagnosis techniques, Kazakhstan could decrease TB incidence by 50% and TB mortality by 11% in the last 10 years. So this is our statistics. And as you can see on this slide, morbidity and mortality in the Republic of Kazakhstan year in, year out is going down. And if in 2009 we had 105.3 per 100,000 people, then as of last year, it went down to 35.7 per 100,000 people. And respectively, the mortality also decreased. So now it's some 2 per 100,000 people, so 1.9 to be exact. So as for MDR TB rates among new and among relapses, so it's the same, like 53, and as for retreatment cases, again, it is stable at the same level. So as for the number of registered MDR and XDR TB patients in 2009 to 2019, so by 2019, like before the pandemic, and even I guess it's the effect of the pandemic as well. So the diagnosis was at a particular level, but in 2020 it decreased because due to the pandemic, many TB centers switched to COVID treatment. They became COVID hospitals, and that's why we are seeing this reduction. So as for the organization of TB laboratories network in the Republic of Kazakhstan, so the reference lab is on the top. We have 20 bacteriology labs. Of them, 19 are in the civilian sector, so provincial TB centers, and one in the penitentiary sector. Also, we have microscopy labs in districts and also in the primary health network. 245. So as for microscopy labs plus gene expert labs, which is done in parallel. So we have 19 labs of that sort. The number of devices to diagnose TB in the Republic of Kazakhstan. So in Kazakhstan, we have 128 GenExpert devices. As for LPA devices, we have 17. As for backpack, we have 30. And we also have other molecular genetic devices, and each provincial center uses its local budget to procure it. So Pioneer from South Korea, and we have Zisan, China. And now the question is, if we have so many pieces of equipment, so many techniques, so many opportunities, was it sensible to procure that expensive technology, sequencing? And when we got that question about phenotypical and molecular discrepancies, and also to ensure accurate forecasting, and also as for projections of drug resistance and for in-depth studies of biological characteristics of TB agents. And then in 2018, there was WHO mission, and the mission recommended that the country procure the sequencing equipment, NGS. And procurement of NGS in Kazakhstan was introduced into the plan and the new application under the Global Fund project, Effective Response to Drug-Resistant TB in Kazakhstan for 2020 to 2022. And with the support from the Global Fund, when the experts indicated in the plan that NGS procurement, we started preparing the premises where we were going to install it, and the rooms for sequencing were prepared. So we installed the air conditioning, procured computers, high-speed internet, then procured the device for by distilled water cleaning, and then UPS was procured. And then the questions were like, what to start with, how to start, what is NGS equipment, what rooms do we need the extra devices, which ones, and how many and which reagents do we need? These were the multiple questions we had. And so that's the story of introduction of whole genome sequencing in Kazakhstan. In 2019, there was the working visit to Kazakhstan by the head of the supranational lab, Harald Hoffman, and specialists of that lab, Vladimir Antonenko. So they considered the facilities in the lab and assessed them and came up with the following recommendations. So at least 3 rooms were required: the room for DNA isolation, the room for library preparations, and the room for sequencing. So the optimal temperature should be +18, and then the air AC unit had to be installed. So high-speed internet should be provided. Good for TB hard drive should be available, and then equipment should be connected to UPS. Then autonomous generator for power generation should be provided. Trained specialists should be in place, and reagent planning for sequencing also needed to be taken into account. Also DNA extraction, library preparation, fragment analyzer, sequencing. The next story is, so all the recommendations from supranational lab meant that they had to be implemented, and then we had to improve the level of understanding of the whole process, and then we agreed that we have to get acquainted with Kyrgyz experience just to see how it was organized in Kyrgyz Republic, the sequencing, and we are grateful for a warm welcome, for good interaction. We are grateful to Kyrgyzstan's NRL, led by Gulmira Kalmanbekova. And then in November 2020, this equipment was supplied finally, the analyzer, and The analyzer was supposed to be supplied in late 2019 and early 2020, and the delay was due to the COVID-19 pandemic. Due to the pandemic, one engineer came, installed it, but the training could not be provided offline. And the installation, the training, like basic training, was provided online. In 2020, what was followed is like, initially people didn't know what a library is, how to do it. And like, then in 2020, in the online mode, the orientation training was provided on the principles of NGS operation with ethical project consultant Vladimir Antonenko. So that training was provided. And since then, they started understanding like what NGS is at all. And then the next stage of training is February 2021, online training session with the ethical project consultants Vladimir Antonenko, Dmitry Sinitsky, and supranational reference lab specialists. Again, online training. So they started genomic DNA extraction and library preparation. So they gave us advice online, and they worked on their own. And then maybe there was some misunderstanding, but at least it's 50% complete. Then the Global Fund suggested that online is no go, so let's switch to offline and provide on-the-job training for local specialists. And then in March 2021, with the support from the Global Fund project, so to our national reference lab, specialists from Nazarbayev University from Nur Sultan were provided, 2 specialists were invited, and they conducted master classes. So starting with extraction of genomes, the sequencing, in fact, at first it was not really successful, so there was some level of misunderstanding, and our practices with Nazarbayev University differed a little bit, and so it affected the results we got. And then in July 2021, there was on-the-job training. So Dmitry Sinitsky and Andrei Golubov, ethical project consultants, came to us, and they jointly with our specialists, from the very beginning till the very end, it all was offline. And then each and every stage, each and every aspect was clear. So we repeated all the procedures after them, and we got the first results, actually quite good results. And the next training stage is August 2021. Offline training, including a 2-week trip to the supranational reference laboratory. So 5 specialists went to Gautim, to that SNRL, with the support from Ethicon, USAID, and the Global Fund. And specialists on their jobs, so using their devices, showed us how it worked, and we repeated their actions. And then we solidified our knowledge obtained before. And then, so this is a good quote, like, if you only knock long enough and loud enough, you are sure to wake up somebody. So these are the first results, like NTS validation in NRL. At present, with the support of Ethical Project, research is ongoing. So confirming operating principles and validation of the whole genome sequencing of MB culture samples. So before our visit to Gautim SRL, our experts at NRL, had 7 samples sequenced, and of them, 6 were phenotypically confirmed. So those were AMDR TB cases. So the DNA was extracted, the library was prepared, and the length of DNA was taken into account. So these are the results we obtained. And so as for those samples, well, so their resistance was confirmed. So in fact, we had 5 of Beijing genotypes, and 1 was susceptible. So to analyze the resistance patterns, so the genes are POB, CAT-G, NDH51. So, and then the full genome sequencing showed the mutations are most frequent in genes RPOB and CAT-G, causing resistance to rifampicin and isoniazid respectively, and also the data suggests the NGS is highly effective for diagnosis and detection of drug resistance. Finally, I would like to extend my deepest gratitude to the Global Fund, to Etika USAID, to the National Laboratory in Galkin, to experts of Nazarbayev University in Nur-Sultan. And in the beginning of my presentation, I've already mentioned the specialists of the National Reference Lab of Kyrgyzstan and our specialists. So we are most grateful for NGS introduction in Kazakhstan. Thank you very much for your attention. Thank you so much, Lala and Gulmira. Thank you so much for this opportunity to get more information on next generation sequencing techniques. And I guess these presentations are of great interest to the countries that only plan to introduce sequencing. And the next floor is given to a representative of Uzbekistan, Laziz Turayev, head of NRL in Uzbekistan, the National TB Service, and the presentation is Laboratory Network Optimization Experience of Uzbekistan. He is also part of the Global Fund project against TB. So Laziz, the floor is yours, colleagues. Hello. So my name is Laziz Turayev. I'm head of NRL lab TB Center. Yeah, thank you very much for an opportunity to speak on the optimization of laboratory network experience of Uzbekistan. And now I will try to share my screen.
Кажется, видно, да?
I hope you can see. Seems like you can. Can you see? Yes, yes, we can hear you, we can see. Thank you. So we are very pleased to, because we heard presentations from our colleagues, Kazakhstan, Kyrgyzstan, and we can only envy them because they started sequencing introduction. Hopefully Uzbekistan will soon make it as well. And in this presentation, I would like to highlight the laboratory network of Uzbekistan, and I would like to discuss the steps towards its optimization. So the laboratory network for TB diagnosis includes 290 laboratories at 5 levels. The difference is the range of diagnostic services and the level of competence. And at the first level, we have microscopy labs. and the primary health care facilities. The second level is gene expert labs. Overall, we have 41. Level 3 is LPA labs. We have 5, and also culture labs are available at hospitals with LPA. And then level 4 is inter-regional, so DST is provided. We have 7 labs like that. Level 5 is national reference lab and inter-regional reference lab in Nucleus City. So this slide shows the lab network by provinces and facilities. So the structure, as you can see, of our laboratory network makes it possible to cover provinces with rapid diagnostic techniques as well as culture. And NRL is a coordination center for the whole laboratory network and ensures external quality control, monitoring, and training of personnel. So one of the key laboratory techniques, as you're aware, is molecular diagnosis using gene expert technology. So in the country, we have 68 gene expert devices.
И 3 в пенитенциарной системе.
And 3 of them in penitentiary system. Despite the fact that we have very good coverage with the rapid diagnostics, we still have problems with regard to efficient use of routine work, and together with the agency USAID, the project to eradicate TB in Central Asia, we've analyzed the current coverage of gene expert for the suspicious cases. After that analysis, we were able to understand that for primary diagnostics, we are well equipped for all suspicious cases, including some, excluding several regions, Samarkand, Sirdarya, Fergana, Andijan, and Tashkent region. The analysis of the demand analysis has been done and needs assessment has been done based on the period of 2014 until 2018. So we were able to identify that despite the reduction within the indicators of the morbidity level, the microscopic examinations has increased 2 times. So one of the explanations of the situation was that microscopic testings are being done in order to perform screening among the population, which principally they were unable to reveal any symptoms of TB. So that's why a different methodology for calculation has been applied. And the methodology was that the follows. For the pulmonary TB, number of suspicious cases were 10 times per registered cases. Within 2018, based on WHO, the number of it was 10,833 registered cases in Uzbekistan. So the number of suspicious cases were equaling 108,333 persons. In order to have proper results, the lab experts and NRL has analyzed the testing results from Gen Expert for 2019 year by regions, and were able to obtain the following results. So the coverage with the test Gen Expert for the 2019 was 89%. So as you may see, 9 out of 14 regions of the Republic of Uzbekistan were able to reach 100% coverage, and only in 4 regions we have to increase the number of tools or the number of modules. Based on the results obtained and the analysis which has been conducted in the Republic of Uzbekistan, and some of them it has been already launched. So to expand the identification of TB and also MDR TB with the help of reorganization of current network. So it's done in two directions. First, we assess the work of microscopic labs, their contribution to identify and detect TB for further reorganization by the GenExpert lab, or to logistic premises. Well, next one, to develop optimal routes for transportation of samples, and also to attract transportation and logistic companies in order to transport the samples. So as for the regions, in Fergana, Jizak, Sirdarya, we were able to identify optimal routes for transportation, and currently there are works are done in order to attract transportation companies to be involved. So it is being coordinated by USAID, TB liquidation in Central Asia. One more project that is being applied, that's TIFA project. They are launching in Tashkent province, and then with the rollout for the whole republic. So here's what we have. This is the work that has been done in Jizak. Next slide shows the NRL. Together with our partners, we develop so-called logistic algorithm for diagnostics of TB, and this slide shows visually the whole route of traveling of all the samples, starting from the sample collection down to the final destination point for culture and for other types of expertise. Well, we have two samples here, and both of them are being placed to a cooler. So if that's a logistic, then it is being transported to GenExpert lab. Then inside the GenExpert, out of those two samples, one is being tested by GenExpert, and the second one, next stage, it is placed again to the fridge, and it's being sent, one sample is being sent to so the one which has been already tested, and the other one which is not processed with the buffer solution. So it is being, and besides, we also sent the cartridge, the GenExpert cartridge, if the result was positive and we were able to identify resistance or not able to identify the resistance. Next, we have the sample which is processed and treated with GenX buffer. We may test it using this novel or new test, Expert MTB MDR test. So I'd like to brag about that. So we have one tool which is provided by CFIT. We have a very interesting joint project with them. So where we test these when we try to pilot this test, and we have certain results. So quite soon these results will be published, I think. And the results are not bad. So the test shown a very high level of specificity and sensitivity, especially to fluoroquinolone and isoniazid. So as for the cartridge with the positive result, the GenExpert cartridge. So as you well aware, our colleagues from South Africa has published an article on the use of ready-made DNA materials which has been obtained from PCR vial of the cartridge, those are so-called diamond chambers. So out of that, out of ref-resistant test, you may also get the DNA, extract DNA, and then you may apply it for high NTB-DRSL testing for the second time. So that's one of the options that we have. And while it will be implemented, until now we will have GenExpert, and we will be able to apply this technology alongside. So second sample that has been also collected, which the one that we've had, we use it to perform hind test for the first and the second row line, and then DNA and the sediment of the sample we may store in the freezer, and then we may send it for the culture to a biolab where cultural microbiology will be done, and also to identify the resistance or sensitivity. I'd like to express my deepest gratitude for listening to my presentation, and I would like to congratulate all our colleagues with a successful presentation of yours. Unfortunately, we were unable to get together and only virtually we see each other. Well, thank you so very much. I hope that next week we will get together. Since in all the countries of Central Asia, we have similar challenges and problems, I truly think that your presentation was very important. Next floor, I'd like to pass to Kazakhstan. That's the experience with QMC implementation in Kazakhstan. Laila Chingizova, the head of NRL Kazakhstan, please. Do you see my presentation? Yes, we do. So experience of implementing in Kazakhstan. So this is success of activities in any lab is identified by the degree of the equipment which is provided and the professional level of the workers. However, in order to improve the efficiency of any lab is to improve quality control management in the lab. So the implementation of quality control, we've started to do it in 29. So based on the decree of Ministry of Healthcare, all the scientific labs and institutions had to be accredited by ISO 9001 to be part of any project. So the first stage in 2009, so the auditors came and they came to train us. The accrediting body sent assessors to us, so they were very much helpful to us. Then, now we were able to develop our own system to meet international standards ISO 9001, 2008. So we were adopted all the documents, mission, vision, policy, and implementation of strategic objectives. So first SOPs has been developed for the current tests. In 2011, we were able to perform the checkup of all the activities. And based on that, we were able to obtain a certificate. So first certificate here's what we have. In the year 2001, we've got it in ISO 9001, 2009. So in 2015, we have performed recertification, and of course, another certificate confirming our compliance has been given for another 4 years. So the SOPs has been developed in 2009, and then in 2018, within the scope of ENCP project, CRL specialist Yelena Romachenko was invited, and current SOPs were updated truly. So new SOPs has been developed as well for reagents, methods, non-compliance, equipment, and then later on, by our own efforts, the experts of NRL has developed all other SOPs, including QMS elements. Well, here are the achievements for today. So Up to date, we were able to develop SOPs of general SOPs, well, document control, inventory management, non-compliance, internal meeting, etc. And second, there were SOPs on methods, collection of pathological materials, sampling, transportation, SOPs on all methods. Number 3, reagents, SOPs on all reagent preparations, etc. And then quality control, equipment management, administration, biosafety. So right now we have the SOPs for all these units. So based on the legal framework that we have, we were able to develop following documents. Guidelines. The first guidelines in 2019 has been developed together with the National Lab Galton, and we were able to publish our guidelines. Then regulations on NRL and also documents and records, management review and management responsibilities document, organization and personnel, client management and customer service. As you may see, all the needed regulations has been adopted and developed. We did it ourselves. Any novelties you introduce, we start, of course, it should be followed with the training. So after being certified by 9001, we decided that we need to obtain ISO 15189. So in 2017, this SRL specialist was invited under GF sponsorship, and training has been conducted. So Mr. Yevgeny Sagalchik. So, and the training course was covering 12 QMS elements. Second training course in 2019, the expert of SRL, Mr. Vladimir Antonenko, has performed a training course on biosafety in anti-TB labs. In 2020, training on quality management system implementation complying with the requirements of international quality standards was conducted under support of ETICA USAID. So in 2020, the QMS audit of the NRL was performed, and baseline audit scores per QMS SLMT were jointly given with the USAID Ethica project. So it was done by Mrs. Oksana, but due to pandemic, it was done online. So, and it was still successful together with USAID project, as I told you. So finally, the result of this audit, here's what we have. A well prepared lab. So we have very good indicators. So the implementation of QMS, as we see, the report with recommendations was prepared based on the SLMTA audit. SOPs and forms has been updated, all of them. So we were able also to develop the QMS documents. So as for the SOPs, we were well supported by our expert, and it was so very much helpful. We also were able to perform follow-on developments. So besides, we will be performing our audits every year. So that's our team. Thank you so very much for your attention. Thank you very much. Next floor goes to Kasımova Guljaman Sadykovna. She is the lab expert of Republican Center to protect population from the Republic of Tajikistan.
Бактериологической лаборатории Республиканского центра и национальным координатором по микроскопии и джен-эксперту. Презентация называется
The presentation is titled Experience of Tajikistan in Transition of Expert Ultra Cartridges. So, the floor is yours. Good afternoon, dear colleagues and partners. Allow me to present to you Tajikistan's experience in transition to expert ultra cartridges. So the Republic of Tajikistan is located in this Central Asia, so it's a mountainous country. So some 70% is valleys, and the Republic of Tajikistan is one of the 30 countries with a high prevalence of MDR-TB, and is one of 18 high priority countries of WHO European region. Despite considerable progress in implementation of the national TB program, in recent decades, the country has faced a number of problems which need further promotion and optimization of efforts to ensure effective epidemic control, especially in ensuring universal access to diagnosis and treatment of all forms of TB. In line with the recent global WHO report on TB, so as of 2019, in Tajikistan, the level of TB case registration is 83 per 100,000 people. The MDR TB rates are one of the highest in the world, 29% of new cases and 40% of previously treated TB cases. So in 2020, one of the most important guidelines were developed for the Republic of Tajikistan for 2021 to 2025, the National Program for TB Protection of the Population, and the Strategic Direction 1.2.1 is to expand the access to early diagnosis of all forms of TB, including MDR, XDR, TB, to increase coverage of expert technology as the primary diagnostic means. So the network of TB laboratories in Tajikistan, the TB laboratories network includes the National Reference Lab, which is classified as the high-risk TB lab, and it conducts all types of laboratory tests, moderate risk, then culture tests, phenotypic, DST, and LPA, high for first and second lines, and at 5 provincial moderate risk laboratories and at 78 district low risk labs. So provincial moderate risk labs and the Rasulov district in Suk province, in the cities of Kulab, Bakhtar, Kharok, and the National Public Health Laboratory in the city of Dushanbe conduct culture tests, inoculation into the primary culture medium, and also direct molecular tests using LPA, Hein, first and second line. And then currently the full test DST is conducted only at the National Reference Lab, and Supranational Lab in Gauting, Germany provides technical assistance to the National Reference Lab and also provides support to improve the laboratory network of the country in the area of quality monitoring and assurance. This slide, as we can see, suggests the expansion of the network, introduction of new diagnostic techniques in 2009 to 2021, and as you can see, this is the map showing GeneXpert technology provinces. So 73 districts are covered and 4 penitentiary facilities. And this map shows that GeneXpert technology started in late 2000 and then in late 2011, and step by step at 2017, and in late 2017, so 31 and new GeneXpert devices were provided, and in late 2020 another 9 devices, and currently in the Republic of Tajikistan we have 56 GeneXpert devices, and we use them in 52 laboratories of the country. So the diagnostic algorithm was adapted in line with WHO recommendations in 2018. So, and GeneXpert became the primary diagnostic technique, and the whole laboratory network is under control by the National Reference Lab. So this is the algorithm which was in 2018, and then in 2020, the diagnostic lab algorithm was adapted to use of diagnostic cartridges, Ultra. So since GeneXpert is the primary test, then the changes were introduced, and this is the second option following changes.
Добрый день. По-моему, мы потеряли
Good
Косымова.
afternoon. I guess we lost Cosimo. Can you hear me? But yes, we can. We can see your presentation. Can you see it now? No. I guess we got disconnected. Okay, let me get connected again. Please confirm. Can you see? Yes, we can. Thank you. The second algorithm is like for and it's for the strategy for a transition to Ultra. So the NCP Tajikistan, with the support of international partners, started switching to Ultra cartridges. So it began from the pilot implementation stage following WHO guidelines on phase transition, and then optimization of the system for transportation of diagnostic specimens to pilot sites, then procurement and supply plan, training and expert Ultra technology, updated diagnostics. So development of step-by-step expert introduction plan, and then the members of the thematic coordinated the implementation phase, then the field assessment was conducted for new cartridges at pilot sites of Sub province, Dushanbe city, and then districts of Republican subordination with further full coverage of the whole country, procurement and supply of expert cartridges, review and optimization of the transportation system for pilot sites, then preparation of trainings. Then the laboratory order, supply of cartridges, customs clearance, registration, distribution of cartridges across regions. As part of procurement using the Global Fund grant, in 2019, expert Ultra cartridges were ordered. They were delivered in 2020 to the country. There were 2 shipments. So the first was like 7,200 units. Expiry date is 26th of December 2021, and the second shipment was 17,300 units. The expiry date is the 30th of January 2022. After delivery of expert Ultra cartridges to the country, the customs clearance followed, registration procedures followed, and then the certificate was received from SRCM, and then in February 2021, expert Ultra cartridges were distributed across districts of the Sud province and Dushanbe city and districts of Republican subordination. And as for transportation system, so from rural areas to laboratories of district level, so the system was organized by the Ministry of Health and Social Protection. So currently the specimens are transported from that level by health professionals, and from districts of Republican subordination Dushanbe to the NRL. The specimens are transported by NTP from district laboratories to provincial laboratories and to NRL. Then, under ETICA project, we also ensure transportation in Rudaki and Baghdad districts. So, training for specialists and doctors. So, CFAID France and ETICA provided training for expert ultra introduction in January and February. Training seminars were provided by USAID ETICA on how to use expert ultra cartridges, and 42 laboratory specialists were trained at Republican, provincial, and district institutions. They were trained in how to use the cartridges, including adjustments in records and reporting, as well as correct interpretation of results. And with the support of the ETICA project, trainings were provided on diagnostic algorithm and the interpretation of results of expert ultra for doctors and lab specialists. So since February 2021, NTP has started implementing expert ultra cartridges in the Sukt province, Dushanbe, and districts of Republican subordination. So currently, expert ultra is introduced at 18 laboratories. The lab shows them as red. So this is comparative statistics for 2020 to 2021. So this slide shows how the case detection rates increased and resistance detection as well. So actually, since April 2020, the caseload dropped, but the number of positives increased, and in July, August 2021, the situation again deteriorated, which also affected TB case detection because of COVID-19 pandemic. And the chart shows how during the COVID-19 pandemic in 2020 resulted. So how the case detection rate dropped, and since COVID pandemic also happened in July, August 2021, again, case detection decreased. And another slide shows the same patterns for rifampicin, for resistance detection, which again went down in July and in August. So the challenges. So human resources, servicing the GX platform, computer skills, laboratory network, infrastructure, internet quality, electricity, thermometers, air conditioners, and so on. So further steps, planning and purchasing of ultra cartridges from 2022 to cover testing, to cover the whole country with testing, then training for remaining sites, laboratory specialists and doctors, then receiving and distributing ultra cartridges to cover all laboratories in the country. Thank you so very much, everyone, for your attention. Thank you so much, Guljamal, for your presentation, for highlighting that topic. And I apologize, I will be quite quick because we are lacking time. The next speaker is Bigzat Taksanbaeva, Regional Advisor for Laboratories, USAID ETICA Project. And respectively, she's been in the health sector for 20 years. And if you are interested in her other achievements, I guess you can check with her later. And thank you so much, Bigzat. Now the floor is yours. Thank you so very much, Dmitry. My presentation is on implementation of phenotypic DSC in TB laboratories in Central Asia. So as you are aware, in recent years, we managed to reach considerable successes in terms of finding more effective TB drugs and developing shorter TB treatment regimens. And since 2018, WHO has been urging countries to fully switch to oral MDR treatment regimens based on new and repurposed anti-TB drugs, such as bedaquiline, clofazimine, linezolid, and zilomonib. And so actually there is a spread of genomic variants associated with the resistance to such drugs. And currently, there are no rapid tests for genetic predisposition to new drugs, and that's why phenotypic DST for new drugs is key to effective MDR-TB treatment and control. At the same time, there are difficulties in countries with getting pure substances because, as you're aware now, pure substances are sold like clofazimine and linezolid, and also there is an opportunity to get free of charge bedaquiline and delamanid for research purposes. But as for getting free of charge pure substances, it entails the need to fill out a lot of registration forms, a lot of documents, and using the example of Kazakhstan, I can tell you that we got pure bedaquiline within 8 months, and as for correspondence for delamanid, it's in progress for 18 months already, and so far the pure substance has not reached the country. This challenge for Kazakhstan is due to the fact that the country has 20 laboratories testing for drug resistance, and getting pure substances for one laboratory takes less time, but since we request it for many laboratories, the process is delayed, unfortunately. And in the recent decade, WHO has developed and issued evidence-based strategic recommendations for TB management. And based on these recommendations, the countries are supposed to build a laboratory capacity for a genotypic and phenotypic DST to rifampicin, isoniazid, and fluoroquinolones, and to perform a phenotypic DST to new drugs, for example, bedaquiline, linezolid, clofazimine, pyrazinamide, and delamanid, for which we have reliable techniques. And introduction of phenotypic DST in Central Asia TB labs started in late 2018, early 2019 in national reference laboratories of Kazakhstan, Tajikistan, and Uzbekistan. So supplies were organized for pure drug substances. So in Tajikistan, in Uzbekistan, they have pure substances, and Kazakhstan has issues with the delamanid supplies. And a series of practical trainings were organized to prepare working solutions and quality control. So to come up with the minimum inhibiting concentrations to determine that for MTB. As you're aware, COVID-19 pandemic has resulted in a lot of challenges in all sectors in terms of training, including training of health professionals, and at the same time, it was an impetus to develop and to find new ways for training, to come up with innovative techniques. So online platforms could be used, online modules and courses, so we could train health professionals. At the same time, as you know, training a laboratory specialist, I guess by 90% is represented by practical training. That's why we had a lot of challenges in terms of training of TB laboratory personnel during COVID-19 pandemic, and new online training and support models were introduced for national TB control programs for DST and quality control of new and repurposed TB drugs in 2020. And as part of USAID EDICA project, the audio-visual equipment was procured for national reference laboratories in 3 countries, thanks to which practical trainings were started for specialists, and thus DST was implemented for the new and repurposed drugs. And this equipment is shown on your screens, so there is a tablet and a camera, and it makes it possible to communicate with trainees, with trainers, and you can monitor the trainings, how the practical sessions are conducted. And So introduction of phenotypic DST. For that, new SOPs for these drugs were developed, trainings were conducted, and then DST started. So this stage is titled quality control, when the laboratories, first of all, had to carry out DST and then share the results with clinicians. After that, the obtained results were analyzed, and if the laboratory failed quality control, then repeated problem analysis was conducted, like if it's a problem at the pre-analytical or at an analytical stage, and then the training plan was again redesigned and the training was conducted again. If the laboratory showed good results, then the DST started in the country, and then the results were issued for clinicians, and respectively regular mentor support and advice is provided by NRL prior to introduction of DST. And such results are available now at early stages. So all three NRLs in Tajikistan, Kazakhstan, and in Uzbekistan demonstrated a high share of isolates resistant to bedaquiline and clofazimine, like up to 10% of all tested drugs. And repeated online trainings were conducted for each laboratory, and recommendations were provided, and subsequent analysis
And
showed
then
the reduction in the number of false resistant results.
Has shown the reduction for 57%. National Ref Lab of Tajikistan was successfully implementing TLT using the interlab comparison, and also the 34 isolates has been checked with 96 matching. So national labs of Kazakhstan and Uzbekistan went through this work for the new reprofiled drugs. And in Kazakhstan, within the framework of the project, we were able to implement all the 19 cultural TB within all 19 cultural TB labs. What are the conclusions? So in 3 countries, we were able to introduce the tests, and the implementation of the test for the drug sensitivity have to be accompanied with the extended training program. New technologies have allowed us to perform training and distance support during lockdown. Besides pandemic, this approach can be applied for these equipment in the follow-on. So it can be also applied for the alternative mechanisms of obtaining the pure substances, BDQ, DLM, up to date. It is covered by a bureaucratic process, of course, and is in need of timely preparation and additional resources for the customs clearance. Thank you very much for your kind attention. Thank you, Begzat. And today I think that, Begzat, please announce our last presenter. Yes, please. It is my great pleasure to present our next speaker, Vladimir. So I'd like to introduce Mr. Vladimir Antonenko, the Institute of Microbiology and Lab Medicine, Gauting, project of USAID TIC, and he is a member of the Global Initiative Group of WHO. Vladimir, the floor is yours. Thank you very much, Begzat, for such an introduction. The time that I have now, I just want to use it to have an open discussion to follow up with your report on implementing the tests for the drug sensitivity. And I'd like to ask the heads of REF labs, national labs, to be ready to support me in this discussion. And I'm truly hopeful that we will be able to get to a consensus and to obtain some feedback from your side in order to strengthen this area to follow on the resistance towards this new drug. So new drugs, as we were aware, they are quite a hope for the 500,000 of drug-resistant TB patients. And we know that resistance starts to prevail, of course, and that's quite obvious. We register new cases of resistance towards those two drugs as well in the republics of Central Asia, and the role of supranational ref labs. Of course, first and foremost, it is a help in performing this research in regard of prevalence of the drug, and of course to coordinate and prospectively communicate with Stop TBT partnership. And also as Begzat has already mentioned, we analyzed last year 34 isolates from patients from Tajikistan, and those patients were at the treatment by new drugs, and out of those 34, 12 were truly resistant to critical concentration of BDQ, 1 per milliliter, and low concentration BTQ 0.5. So we had matching with repeated results from National Ref Lab of Tajikistan. So it was 96% matching. So moreover, all those isolates has been approved as well, confirmed by the new generation, and they had certain mutations and within the gene, and also they had cross resistance to the LZD. So, and some of them were resistant to DLM, and one strain was resistant to all 4 of them, imagine. So now, as for the most interesting part of that, all resistant isolates do belong to different genotypes, and we've excluded also the recent chains of transfer. So right now, I'd like to discuss with you and to hear from you. What is your vision of the following work and performing surveillance over the resistance towards new drugs? How together we may overcome this threat, this challenge, very serious one, and the baselines for these discussions could be the following areas. So we have truly minor information about the resistance mechanism, and during plenary session we've mentioned that we do not have enough data, so that's why none of the mutations were find its way in confirmed list. Critical concentration do not have any specific clinical proof. Lack of collections, which has been characterized, and we're talking about isolates with the resistance. Not always communications worked well and data sharing. So accessibility of reagents, as Begzat has mentioned, sometimes it is quite a bureaucratic process while we get in Central Asia all those consumables and reagents. There are problems with the external quality control. There are some difficulties with transferring the isolates. Not always it is possible to recheck resistant isolates due to the budgetary restrictions and financial support for the surveillance again. So I'd like to pass the floor right now to the heads of the national Ref Labs. Colleagues, you only have couple of minutes, and we truly want to have your comments on the topics which I voiced. So let's start with Laila. Are you ready? Good afternoon, Vladimir. I'm still thinking. Can I take next floor? Yes, who is ready actually? Gulmira, are you here with us? Yes, Vladimir, I'm here with you. I'm happy to see you. Yeah. This is reciprocal. So how do you think, what is very much needed for the National Ref Lab of Kyrgyzstan in order to perform better the function of surveilling the resistance towards the new drugs. Right now, currently, I may say under the Kyrgyz Ref Lab, we've introduced testing for different drugs. So, and I'd like to say thank you so very much, Vladimir, for the work that you're doing. And I truly think that maybe it is quite ambitious objective, but I think we may switch to interregional, Central Asian regional collaboration, I think, in performing surveillance over those strains inside the region. So due to our joint efforts, well, internal quality control is being performed, which is mentioned by Laila and Begzat. So they work well, and we may produce quite strong and quality results. But it will be very interesting to follow the trends and dynamics, because in our region, labor migration is well developed, both internal and external. And the support on behalf of our partners is tremendous, and I truly hope that you will support our approach. So you propose to develop a regional program to exchange and to share resistant isolates, right? For the inter-lab matching to be done between Kyrgyzstan and Kazakhstan and Tajikistan? Maybe I wasn't able to properly express my thought, so maybe that's why I have to add on my answer. Taking into account then that in Kyrgyzstan, it is full genome sequencing implementing already. So as for the in-depth analysis, well, we have to train and train. So the technology is being implemented. Laila has provided us this very interesting report on implementing sequencing in Kazakhstan, and Laziz in his presentation has mentioned that they're planning on doing that. Why wouldn't we use this instrument to monitor, to perform surveillance and monitoring, to perform epidemiological surveillance, not at the phenotypic level, but that should be also done, but to be done at the level of molecular and genetic surveillance. So maybe this is too ambitious, of course. That was great proposal of yours, but the only thing is that it's very much important also to see the correlation between different mutations. So what do you think about, let's say, for all resistant isolates, to provide titering based on concentration, based on like lower level concentration or higher level concentration? What do you think? On the support of USAID, within the framework of the project, we were able to, you actually conducted a lot of work, similar work at your supranational lab. We've got very interesting results, and we will be analyzing them. So yes, indeed, titering produces a lot more information, generates a lot better information with regard to the resistancy identified. But if it will be also linked to the results of sequencing, and we are able to find resistant strains, and we see the titering at the minimal inhibition concentrations, and we decide to sequence those results and to try to search for the source from where this or that strain came in from. Well, that would be just beautiful. Thank you, Gulmira. Thank you so very much. Colleagues, who else would want to express their opinion? We only have a couple of minutes, truly. Truly, moderators are pushing me, really. I completely agree with Gulmira. Truly, it would be very interesting for me to know how it truly works in neighboring countries, because we have labor migrants from Uzbekistan, from Kyrgyzstan. So it would be very interesting for us to find out what strains are traveling there and from. Yeah, but that would probably resolve the matter of the problem with transportation as well of isolates to Europe, right? So for us to be able, just traveling by cab, we would be able, Dmitry was unable to come by cab to you, but still, I truly am hopeful that it can be organized, right? Okay, thank you, Laila. Colleagues, any more final remarks? Or shall we call it a day? No, Vladimir, a couple of words only. All the problems has been already voiced by you, and these problems are subject to be resolved. Those problems are there on the screen. As for the titering, I may say that new projects, for example, TB Alliance, for example, it foresees titering of this new drug, critamonid. So it's covered by the algorithm. So at least we have to start with that. And indeed, what is being proposed by the colleagues to exchange strains, etc. Well, it's beautiful, but we need some legislation to be involved, right? So there are some obstacles to do that, right? Of course, it's an obstacle for the regional level. I'll be frank with you. Thank you, Vladimir. Hi, this is Alexander. We have raised hand from Alikaden. Thank you. Good afternoon. Thank you so very much for the given floor, my dear colleagues, my dear friends. I just wanted to tell you, I'm echoing the previous speakers in order to follow on with such an exchange of isolates or any statistic data. For that, we need a resolution or an edict, or maybe during this conference, one of the outcomes of this conference should be a development of certain recommendations, like memorandum of collaboration and understanding was initiated by Kazakhstan to sign among the government. So we thought that it will be done at the level of the government and then at the level of ministries. Well, unfortunately, we only had one with Turkmenistan, and this is it. So no one is objecting, but no one did anything for that to be fulfilled. So if that's possible to be done, so that legislative document would allow to pass on data and data on patients and everything, and maybe the lab data as well. Thank you. Malik Moldagbetovic, thank you very much for a very valuable comment of yours, and I kindly ask moderators to introduce this information to the resolution. Yes, of course, will do. Gulmira, we see your hand is raised. May I, Vladimir? Yes, please. One more thing I'd like to talk about, and that's, I hope that my neighboring countries' colleagues will follow me on. So external quality control with regard to cultural research. I'm talking about culture itself. So unfortunately, in all the countries, we have a network of microbiology labs for culture, but the external quality control is not done. So I don't know, but the matter should be discussed, of course, on the necessity of establishing or developing similar program. Thank you, Gulmira. Well, we want to try it in Tajikistan, but still we have problems with sending the materials to each other.
Two carriers, we tried them, and actually to no effect. We are waiting, but the panels are available already. And Volodya, we have a suggestion. So customs clearance and similar procedures require some efforts, resources, attention, but the processes are somehow streamlined in our country. So the suggestion is let's try it in our country. Okay, let's give it a try. Good. I fully support it. Thank you, Gulmira. Colleagues, I have to interrupt our discussion at this point of time because we are running out of time, and let me give the floor to a facilitator to wrap it up. Exam, the floor is yours. Thank you very much. I would like to thank all the presenters for very interesting presentations. So thank you. Unfortunately, time is limited. Thank you so very much. I would like to thank our co-moderator, Dmitry Sinitsky. So the floor is yours. And after that, we will switch to another session for a wrap-up session. And I would like to say that actually we have questions on other presentations as well, but since there is no time, if you still have questions on other presentations, please contact the presenters, and then as part of your personal exchange, you can get the answers. Thank you so very much. We are finishing it here. And thank you, Big Zat, for your work as well. And let's see each other at the next session. Dear participants, please follow link 1 for a wrap-up session of day 1. Thank you so very much.